What if you could figure out the most likely source of your back, butt, hip, or leg pain for free without needing an x-ray or MRI right now? Let's do it. In this video, I'm going to walk you step by step through the most complete and in-depth self-diagnostic flowchart you have ever seen so that you can identify the root cause of your pain. And a quick warning, do not skip ahead. We're actually going to walk through this in a very specific order. We're going to start with symptoms felt only in the lower back. We're going to work through the pelvis, into the buttock, down through the hip, and into the leg. And we're going to cover various diagnoses or reasons why you might hurt so you can figure out what could be going on. So we're going to talk about things like disc issues, facet joint problems in the lower back, degenerative joint disease, arthritis, spinal stenosis, sciatica, SI joint pain, hip arthritis, hip bursitis, glute tendinopathy, hip impingement, piriformis syndrome, high hamstring tendon problems, and we're going to talk about something that's commonly overlooked that can cause any physical sensation, very real by the way, in the body, which is the role of the brain on the pain or symptoms that you might be experiencing. So stick around for that. So you're here because you have some form of lower back, buttock, hip, and or leg pain. And we're going to talk about all these different diagnoses. But before we do, we need to make sure there's nothing big, ugly, and scary causing your symptoms. Things like cancer, fracture, or infection. So we're going to rule these things out first, and we do this by screening for clusters of symptoms we call red flag findings. First things first, cancer. Is cancer causing your back pain? A very common question I get. Well, we can screen for this. So cancer is not very common as to the cause of back pain, but it can occur, and we see that roughly 6 out of 1,000 people who present to the doctor, if you will, with back problems may have a tumor or cancer as the cause of it. So what's the cluster of findings that increases the probability, when present, that cancer is the cause of your pain? Well, what we see is that if you're greater than 50 years old, if you have a previous history of cancer, that's actually the biggest predictor of cancer being the cause of your back problem. If you have unexplained weight loss, and if you've failed to respond to natural treatment, then the chances, again, go up. Now, that being said, given this article, for example, it says, cancer-causing back pain can be ruled out with 100% sensitivity, or we'll say certainty, if you, the person with pain, is less than 50 years old, does not exhibit unexplained weight loss, does not have a history of cancer, and is responding to natural treatment. Pretty cool. On the flip side, if you have a previous history of cancer alone, or 3 out of 4 of these findings, then generally we would recommend that you get referred out for some type of x-ray and or blood work to screen for an elevated ESR, erythrocyte sedimentation rate, essentially a marker of inflammation in the blood. All right, so that's cancer. Now, fracture. Is fracture causing your problem? Well, again, not very common, about 1 out of 100 people, actually a little bit less than, taken from this article. Again, a cluster of findings which, when present, increase the probability that fracture may be the cause of your issue, and you might want to get that checked out. So if you are of female gender, if you're greater than 70 years old, if you have significant physical trauma, that is related to the onset of your symptoms, so maybe you fell, you had an accident, something like that, and you have a history of prolonged corticosteroid use. So we know that people who have taken steroids over a long period of time generally have more brittle bones. It tends to reduce bone density over time. So I'm going to recommend that if you have 3 out of 4 of these check marks here, that we get some medical imaging. And while I'm not the one maybe to make that call, go see your primary care doctor to rule out fracture. All right. Now, infection. Well, if you have back butt sciatica symptoms that are associated with, you just not feeling well, and there seems to be some correlation there, such as you have a fever of greater than 100.4, that's how we define a fever. You have body aches, you have chills, nausea, fatigue, just not feeling well around the time your back stuff started, as well as redness and swelling, then it's possible that an infection could be causing your back pain. All right, so there you have it, infection, fracture, cancer. Now let's get to the good stuff. Let's talk about more common causes of back, butt, and sciatica problems. And again, we're going to start at the top with only having back pain. Well, what could be the cause? Well, we know right off the bat, based off some different research, that there's roughly a 41% chance that disc is the cause of your symptoms, a 31% chance that the facet joint, the joints in the spine, we'll talk about those in a moment, are the cause of your pain, 18% SI joint, 10% nerve. And if you only have lower back pain, well, it's possible it's just central, so smack dab in the middle, or it kind of spans right to left across the belt line, or maybe it's just one-sided, right, in this flank area, or just off the side of the right or left of the spine. Either way, let's start from the top. So let's just say that your back pain is central and or spans across the level of the belt line. Well, immediately, just knowing the location of your symptoms, being this is all you have, the probability of it being a disc issue skyrockets, roughly 75% from a baseline of 41%. So pretty darn sure it's a disc issue right off the bat, given the location only. Pretty cool. Now, you might say, well, what kind of disc herniation? Well, there's many different types. There's large disc protrusions or herniations. We'll use those two terms interchangeably, herniation, protrusion. There's extrusions, whereby there's a tear in the outer wall of the disc, but the jelly is still intact. And then there's sequestrations, oh my gosh, right? Jelly is out the donut, and a portion of the disc material is broken off and becomes a free-floating fragment inside of the spinal canal. It sounds really bad and often hurts very bad, but the good news is, a little off topic here, that the worse the disc herniation, the better your chances for natural healing. So don't give up, okay? Now, the reason we have an X next to these types of disc problems is because they almost always irritate nerves in the spine, which are known to cause symptoms below the level of the knee into the foot. So the fact that you only have lower back pain, we can essentially say, probably not those. Now, what's more likely is that you have a one-sided disc protrusion or herniation. They almost always go out and back to one side. There's actually a ligament here, so they can't go straight out the middle. They kind of hit the meridian and pick the right or pick the left for whatever reason. And this cluster of signs and symptoms, again, further increases the probability of the disc being the cause of your problem. So age, does age matter? Yes, we see that disc herniations are more common in people who are younger, less than 50 years old. It doesn't mean that if you're older than 50, you can't have a disc problem. It just means that it's more likely the younger you are. You'll see that it is central to one-sided as far as where the pain manifests. And it can be along the belt line, it may be smack dab in the center, or it may shift from one side to the other. So as you'll see here in a moment, central, but it can just cause one-sided back problems. There is often trouble straightening or standing up after a period of sitting. A lot of stiffness, a lot of pain, and it feels like you just can't stand up. You have to take a moment to get straight. Pain is often worse in the morning because disc pressure is highest in the morning. Pain is often, but not always, worse with sitting, driving, bending, lifting, and twisting. This is actually often what people describe as their mechanism of injury, how they hurt themselves. And then coughing and sneezing or straining, something we call the Valsalva maneuver, actually increases intra-abdominal pressure or intradiscal pressure, pressure within the soft tissues of the spine. It can increase pain. Pain is often, but not always, better with walking, standing, being upright, or lying down. And there's often this history of a roller coaster of back pain, whereby the back, went out in the past, then it got better, and then it goes out again, and you just kind of always have your back going out on you every few months or something like that. Now, again, if it goes out and back to the right, you'll almost always have right-sided symptoms, but it could be central as well. But you might also be shifted. So it's possible if you only have back pain that you could have what we call a lateral shift, whereby you have a disc herniation out and to the right, well, you want to get away from that. So you will bend forward and shift your body to the left, sort of intuitively, all right? There's a block there, if you will. And so we call this a left lateral shift, named by the orientation of the shoulders relative to the hips. So you can see the shoulders are to the left and the hips are to the right. We would call this a left lateral shift, and this person would be crooked, a telltale sign of a disc problem. If it's back and to the left, well, you go forward and to the right. That's the way your body will move. All right, so we would call this a right lateral shift, again, named with regards to the direction that the shoulders are going relative to the pelvis. All right, so that is disc herniation as the most likely source. Now, let's just say that you don't have central lower back pain. You only have left or right-sided back pain, just off the side of the spine or kind of in this flank area over here. Well, what's the most likely cause? We see, again, disc problems can cause just one-sided back issues, but facet joint problems become a little bit more likely. The probability goes up. SI joint nerve pretty much goes to nothing. Now, facet joint. What is the facet joint? So facet joint, a degenerative joint disease, by the way, arthritis, all these things can affect this area of the spine, which is the junction between the bones. So you have the vertebrae, L4, L5, and you can see there's a joining of those two. We call this the facet joint, and there's one on the right, there's one right here, there's one up here, and they're on the left as well, so on either side of the spine. And we see that these things are more common. So are you greater than 50 years old? You can see here, age plays a role in that disc problems were more common if you were less than 50 years old. But as you get a little bit older and wiser, facet joints become the more likely cause or a more likely cause of symptoms. Right? Taken from some research as it relates to screening for facet joint problems, we can see again, symptoms are almost always off to one side at a specific level. There's very rarely, if ever, pain when getting up or transitioning, unlike disc problems, which do cause pain with transitions. And again, unlike disc problems, which note increased pain with coughing, sneezing, and straining in many cases, facet joint problems don't experience that. And well, you might say, well, why? Well, if you think about it, it kind of makes sense. So a disc is a soft tissue, and you can change the pressure within soft tissues when you cough, sneeze, or strain. But facet joint problems, degenerative joints, arthritis, they're bony problems. When you cough, sneeze, or strain, you can't change the pressure inside of that bony system, all right? And pain is often better while walking or sitting. Not super helpful, but that's what we found. And then finally, this is something that I want you to try. So you'll see these self-movement tests sprinkled throughout this conversation. I would recommend you give them a go. I'm going to go ahead with the different possibilities as far as results, but you can stop this and try it for yourself, okay? So we call this a rotation extension test. So what I want you to do is I want you to stand on up, and I want you to first, before you bend backwards, rotate your trunk towards the painful side. And then I want you to bend backwards. I want you to see what it feels like. And it's often positive, so often painful with facet joint problems. You're clamping down or closing down on that arthritic joint or that irritated joint. Now, if it's possible, I want you to go ahead and I want you to do as tolerated up to 10 reps because I want to see what happens the more you do it. And it would make sense if it's a bony problem. You're probably not going to change that bony problem very rapidly. So many times people say, ouch, that hurts, Charlie. And oh, by the way, the more I do it, it either stays the same, on, off, just the same level of pain, and or it worsens. It hurts more with more repetitions. And if this is the case, then this increases the probability of facet joints being the issue because we see an absence of what we call centralization. Centralization, we'll get into it here in a little bit, but it's this phenomenon that's almost always associated with disc problems, whereby with repeated motions going into a motion that's maybe a little bit painful or restricted, you can often see that symptoms move. So if you have symptoms that are on the right side of the spine only, a little bit off to the right, you might see that they move to the middle. And or you might see that they're rapidly changeable and they completely go away after, say, 10 reps. That is not something that happens with a bony problem. Bones aren't that rapidly changeable. So the fact that that didn't happen, symptoms stayed the same or got worse the more you did it, points to more of a bony problem, probably facet joint. Let's just say, ouch, Charlie, I feel that. But actually, the more I do it, the better it feels. It gets more loose, the pain feels less, or it moves around. That points towards centralization. That's not common with joint problems. That's common with soft tissue problems. That's an indicator of a disc, highly predictive of or diagnostic of a disc problem. You can see the probability, boom, shifts rapidly towards it being a disc issue. And again, we call this centralization. I had pain right here to the right side of my spine in this example. The more I did it, it moved to the midline. It got stiff across my lower back. And or it went away. It got much less. We would call this centralization, all right? And again, that's associated with disc problems, all right? If that doesn't hurt, well, a lot of people would do this. Again, disc problems are often made better by being upright, standing, walking, and oftentimes bending backwards. It's the most common sort of movement that someone might have a preference for if they have a disc problem. And so it's possible as you're bending backwards that it actually gets better the more you do it, or it doesn't hurt at all. And it just kind of feels good. So again, that would increase the probability that it's a disc problem. It would reduce the probability that it's a facet joint issue because again, if you have a facet joint problem, an irritated joint, when you close down on that bad boy, it should hurt, all right? Okay, now, let's go back to this. Again, you've only got back pain, but Charlie, notice nowhere in here did you say anything about muscles or fascia. To my knowledge, there is no high-quality studies and or enough data to suggest that myofascial components of the body, muscle fascia, are significant contributors to back pain. So despite what many people believe, all those gadgets meant to release things, lengthen things, get rid of knots, all that stuff, we do not have high-quality data and or evidence, research, to suggest that these problems significantly contribute to back problems, okay? All right, so that's done. Now, let's move on. Let's just say you have lower back pain and one-sided buttock pain, like I show here, with or without leg pain above the level of the knee. So the pain stays above the level of the knee. You got back stuff, you got one-sided buttock stuff, right? And the symptoms stay above the level of the knee. By the way, this is often described as dull, achy, deep, or hard to pinpoint. What could be going on? Could be a couple things going on. But again, highest likelihood is a disc problem referring pain in your butt and or in the back of your thigh. Now, what kind? Like I mentioned earlier, could it be a large disc protrusion or herniation, extrusion, sequestration? Maybe, but probability is very, very low because, again, these things typically irritate nerves, which cause symptoms below the level of the knee into the foot, which we'll get to here in a moment. So most likely a one-sided protrusion out and back to one-sided. Again, these things are more common in folks who are less than 50 years old. Age does play a role in predicting the source of symptoms. Central or one-sided, may shift from side to side, can absolutely cause you feel referred pain into the buttock or the back of the thigh. Trouble straightening or standing up after sitting. Pain is worse in the morning often, highest pressure in the disc in the morning. Like we talked about, usually worse with sitting, driving, bending, lifting, twisting, but not always. Coughing and sneezing increases that disc pressure. Pain is better, often, but not always, while walking, standing, or lying down. And again, the roller coaster of my back went out, then it got better, then it went out. And so if you have right-sided disc protrusion or herniation, almost always you'll feel symptoms on the right side of the body. Right back, right buttock, right thigh. And if you are going to be crooked, you're generally shifted away from that into a left lateral shift. And if you have a left-sided protrusion, symptoms, left butt, left thigh, right lateral shift to get away from that herniation. All right, so that's disc. Now let's zoom back out. But it could also be a facet joint problem. So facet joint problems as well as disc problems can cause you to feel pain in your butt and or in your leg. They can send signals down into the leg. So again, greater than 50 years old, facet joint probability goes up. As we talked about, you might feel pain in the butt and or the leg, but if you have the onset of your pain, if your pain started on the side of your spine in this area, facet joint probability goes up. No pain when transitioning, no pain coughing, sneezing, or straining. Pain better while walking or sitting, and you have a positive rotation extension test. Again, stand up, rotate towards the side of pain, bend backwards. Ouch, Charlie, that really hurts. And the more I do it, if tolerated, of course, up to 10 reps, the pain stays the same or worsens with each rep. So we see no centralization, meaning the pain does not move around and or it worsens. Again, this increases the probability that it is a facet joint problem. Let's just say, ouch, Charlie. Yeah, I feel that, but the more I do it, the better it feels. It makes my symptoms feel better. Then, points to a disc problem. Centralization, again, the movement of symptoms from further in the body, in this case the butt and or the back of the thigh, closer to the midline. So if as you did those reps, you felt, here was my pain, and then my pain went here, and I still feel it, it's in my back, or you know what, it was in my thigh and now it's in my butt, those symptoms moved from further in the leg closer to the spine. We call that centralization. Or maybe your symptoms went completely away, centralization. That is, again, highly predictive of disc being the problem. And well, if doing this motion does not hurt, then again, you might just have a preference for that specific motion of your spine, and maybe it is a disc problem. So those would be the two most likely causes of pain in this area: facet joint and or disc issues. Back, one-sided buttock with or without leg pain above the level of the knee. Now, let's just say that you have lower back pain with one-sided buttock and leg pain with or without numbness or tingling that travels down the leg below the level of the knee into the calf, shin, or foot. And this is often described as sharp, shooting, electric, burning, cut my leg off, Charlie, type pain. Really painful stuff. The first thing we want to do and or perform is a self-movement test. I call this straight leg raise test. All right, we're going to do this. You could do this on the non-painful side first if you want to see, but I would recommend you do it on the painful side to begin. Now, word of caution, go slow. So start, lean back in the chair, heel on the ground, just start raising it slowly. Oftentimes this is a very sensitive test in that it's easy to reproduce symptoms and very clearly will be painful if you have what we're going to talk about here in a moment. But go ahead, perform this test just one time and you'll know, is it painful, is it not painful? And let's talk about it. So if you say, ouch, Charlie, that hurts, and it reproduces your leg pain, numbness, and tingling, then chances are you have sciatica, irritation of the sciatic nerve. Now what I want you to do is I want you to try that straight leg raise test, the same thing, on the pain-free side. And we call this a crossed straight leg raise. And if you do that leg raise test on the pain-free side and you say, ouch, that hurts, and it causes you to feel pain on your painful leg, so let's just say you have pain in your right leg, you did the leg raise, you were like, ouch, that hurts. Probably sciatica, almost definitively. Now go ahead and do it on your left good leg. Remember, you have one-sided pain in this example. So do it on the good leg, do it on the pain-free leg, called a cross straight leg raise. And if you say, ouch, that causes me to feel pain on my right leg, my painful leg, then we call this a positive cross straight leg raise test. And this increases the probability pretty substantially that the disc is the cause of your symptoms. and or what we call radicular pain. So we talked about referred pain. So you can have kind of this dull, achy, hard to localize type of pain, referred from a joint and or from a disc, from any structure in the spine. It can cause you to feel symptoms down your leg, usually not below the level of the knee, usually above the level of the knee. But if you have symptoms in a very narrow band, electric, burning, shooting, you've got a painful leg raise, now you've got a positive cross-straight leg raise, disc is the problem, and without a doubt it's what we call radicular pain, nerve pain. Either way, it doesn't have to be positive. It's just more diagnostic of. It shifts the probability even higher that disc is the likely cause of your sciatica. Remember, sciatica is a symptom. There's something cause it, in this case, a disc. But let's just say raising your pain-free leg is fine. You have a negative cross-straight leg raise test. Disc is still the most likely source. Now you might say, well, what kind, Charlie? Let's talk about it. So, what kind? Well, it could be a one-sided herniation. Could be just one-sided. And again, like we talked about, here are the signs and symptoms that increase the probability that it's just a one-sided herniation or a herniation in general. Age less than 50, again, generally younger. Central one-sided lower back pain along the belt line that may shift from side to side associated with this leg numbness tingling that you're experiencing. There's often trouble straightening or standing up after sitting, pain worse in the morning, highest disc pressure. There's pain worse while sitting, bending, driving, lifting, all that stuff. There's pain worse while sitting, driving, bending, lifting, twisting. Again, this is usually how people hurt themselves. Again, coughing and sneezing increases pressure in the disc, so you'll say, ouch. Pain is often, but not always, as you see here in just one moment, better while walking, standing, or lying down. And again, there's this roller coaster of back pain. Often before this, there was just back pain. And then it got better. And then, they threw their back out, and now it's back pain and buttock pain. And now, if you're here in the flow chart, there's sciatica, full-blown sciatica. So oftentimes you'll see back goes out, gets better, and it just gets worse over time if you don't do anything about it. All right? So right-sided disc protrusion or herniation will often cause right-sided symptoms with you shifted away, but not everyone's shifted. But if you are going to be shifted, usually it's away from the side of symptoms. Left-sided symptoms, and a right lateral shift, shoulders to the right, pelvis to the left. Okay. Now, could it be a large disc herniation, extrusion, disc extrusion, or disc sequestration? Absolutely. I see this commonly. And in these cases, if these are the cause of the pain numbness tingling in the one leg, then oftentimes unloading feels best. Lying down or decompressing, getting off your feet. Pain may actually be better while sitting or reclined. And you say, whoa, Charlie, there's no way I have a disc problem. I was told that disc problems hurt when you bend, lift, and twist. Well, I kind of just mentioned that, but I said not always. With these types of disc herniations or disc issues, you'll often see that sitting or being reclined actually feels better because it unloads the tissues that are irritated in the spine. Pain is often worse while walking and standing, loading the spine. You'll often have a yucky back bend, but Charlie, I was told to do press-ups and back bends because that's what's good for me, right? If you have a disc problem. That's a problem with treating the diagnosis, not treating your pain experience and your response to movement, your movement-pain relationship. So if you've got a yucky back bend, it still could be a disc issue. You might actually love bending forward. And here's why, really cool. Here's actually an MRI of someone who is standing and bending forward and bending backwards. And you see here's a disc extrusion. And you see here's a disc protrusion. And what we see is that bending backwards actually increased this large disc protrusion. And the same person bending forward, the disc was intact, the intact disc actually pushed the protrusion back. And so this person responded really well to bending forwards. Bending backwards actually made them worse. So be careful. Just because you have a disc problem doesn't mean you should be bending backwards, all right? You might actually need to move the opposite direction or do something completely different. Along those same lines, you can see here from another article, they took an MRI whereby they looked at the size of the foramen or the size of the holes where the nerves exit. So in red there, I've highlighted the size of the hole where the nerves are, and this is, just to depict the nerve, the yellow thing there. And you can see that when this person bends backwards, if there's a disc there, which is already taking up space in the foramen, then when you bend backwards, it further causes compression of the nerves. It even further lessens the space that the nerves have to function. And when you're bending forward, you can see that you may actually be able to create more room in the foramen such that the nerve has some room to breathe. Pretty cool stuff, all right? So there you have it. And again, you may or may not be shifted often away from the painful side. Now, you talk about what kind of disc herniation. Let's talk about which nerve is affected. So the L5 nerve is the most commonly affected nerve by disc issues and other issues in the spine. About 50% of people who have some type of nerve problem in the spine will have the L5 nerve that is the main affected nerve root, okay? And you can see here from a pain drawing that the location of the L5 nerve issues are almost always on the back side of the leg. They kind of go to the side of the leg too, and a little bit maybe on the outer portion of the leg if we view from the front. If it does go all the way down to the foot, one way to differentiate, because you'll see here the S1 nerve actually is all down the back of the leg too, pretty much. So they can be very similar in the way they feel, but you will see that if you look at the top of one's foot, symptoms are often felt towards the big toe versus the next nerve here, they're felt on the bottom of the foot towards the little pinky toe. Okay, so nerves are wires. They carry information such as feeling and movement. So an L5 nerve issue can cause feeling problems or tingling, numbness, bunch of weird feelings in this area. And it can also cause you to lose strength, so you to lose function of the muscles, specifically in the big toe and the shin. So one test you could do, if you're curious to see if you have any type of damage or compression to the L5 nerve, is to try walking on your heels. And you often see foot drop, foot slap, things like that, or the inability to pick this foot up. You'll see the foot dragging, okay? Now, the next most common nerve, 46%, is the S1 nerve. So where do you feel this? Pretty much nothing on the front of the leg, all exclusively on the back of the leg, and again, on the heel, the sole of the foot, not the top of the foot, the sole of the foot towards the little toes. Again, nerves carry information such as feeling and movement, so they supply strength, if you will, to the calves. So what you could do is go ahead and try to raise up on the toes or do a calf raise on your good side. Do as many as you can, and then try raising up on your toes on the bad side. And if you do have an S1 nerve problem, you'll almost always see that it's very difficult to go up on your toes, and it'll be very clear if you do have an issue. All right, so how many can you do on your good side? How many can you do on your bad side? And they should be roughly equivalent in most cases. All right, so that's that. And then the L4 nerve. So not very common, so 4%. So L5, 50%, S1, 46%. Now we're at what? We're at 96%. And so very small percentage of people have an L4 nerve problem, but it is possible. And here you can feel sciatic on the front of your leg because the L4 nerve supplies feeling to the front of the leg in this distribution, but you can also feel some symptoms on the back of the leg. So it's not perfect, these maps, if you will. All right. But what you can do, just like the L5 nerve supplied strength to the front of the lower leg, the shin muscles, and allowed you to walk on your heels. The S1, remember, was toe raises. Well, this is a sit to stand. Your quadriceps, your thigh muscles in the front of your thigh, are supplied by the L4 nerve predominantly. So what you can do is a single leg sit to stand test. Go ahead, perform a sit to stand test on your good leg. Do as many as you can. Then try your bad leg and see if there's a very clear difference side to side. Now what I want you to do is I want you to do a self-movement test called the belly knee bend test. If you suspect that the L4 nerve, again, only 4% of people watching this, is the issue. So you already have a positive straight leg raise, and we know that because you got here via it. But go ahead and do this belly knee bend test. It's really called a prone knee bend test, but belly sounds more user-friendly. So lay on your belly and go ahead and just bend the affected knee up, just like I'm showing you here, like you're trying to touch your heel to your butt. And if you have a yucky leg raise, which again, at this point in the flow chart, you have a yucky leg raise. You may have a yucky good side leg raise. So you have a positive straight leg raise, meaning it causes pain, numbness, tingling, restriction. These straight leg raise tests pulls on the L4, L5, S1, S2, and S3 nerve roots because those make up the sciatic nerve. And when you do, if you do this belly knee bend test, if it's painful, causes pain, numbness, and tingling as well, and is limited compared to the non-painful side, then this points to an L4 issue because L4 is common between the femoral nerve and the sciatic nerve. So it points to an L4 issue. Now, let's take another scenario. You have a positive straight leg raise, but then you do this test and it's fine, it's green, it's good to go. Well, that means the L2, L3, L4 is likely fine. And we know, we just talked about, L5, S1 is the most common issue. So then you would refer up to here, right, to see which nerve is most likely affected. Is it L5, is it S1, what is it? All right, so just a way to differentiate there via some sort of movement tests to determine the most likely source of your symptoms. Okay, so L4, not very common, but it can occur. Now, something to consider here, if you have a loss of strength, you're unable to walk on your heels, again, L5 nerve problem. If you're unable to walk on your toes, S1 nerve problem. If going sit to stand is a problem, L4 nerve problem. And you have a loss of feeling, and I'm not saying like it feels weird. I'm talking like, hey, you poke yourself with a pin and you can't feel it, and or you have a loss of bowel, bladder function or control. And we would call this lumbar radiculopathy, loss of bowel, bladder control, we call it cauda-equina. And this would be a referral out, most likely get an MRI by an ortho surgeon as far as opinion. Now, there are many people we work with who do have weakness with these issues, and you can still heal naturally. So just know it's not like an automatic, hey, I need surgery, but it is a sign, right, that we might want to monitor these things and have another second opinion, if you will. Orthopedic surgeon, MRI likely. All right? Okay, so we're back here. Let's just say that you did this leg raise, and it was a little tight, but not that bad. No major problem, Charlie. Great. Well, then that tells us with a high degree of certainty that you likely do not have sciatica. This test is so good, folks. If you do this test and it is negative, it's a highly what we call sensitive test. It's a good screening test for sciatica because we know that if you do it and it does not hurt, there's roughly a 90 to 95% chance that you do not have sciatica. If you have a sensitive sciatic nerve and you stretch it, it should hurt. So what are the likely causes then? Well, the first most likely cause is spinal stenosis. So you've got back, butt, leg pain goes below the level of the knee into the foot, probably some numbness and tingling. There is a cluster of findings that increase the probability that your symptoms are due to spinal stenosis. It is possible that you can have a positive straight leg raise with spinal stenosis, but oftentimes I will see that the leg raises are negative because spinal stenosis is more of a compressive problem versus a disc problem is more of like an inflammatory problem whereby the disc material really sensitizes or irritates the nerve root. Okay, so your symptoms tend to be fine when there is no compression through the joints and through the areas of the spine which are prone to stenosis. So if we look at this article here, there are 5 different items, if you will, that in a cluster increase the probability that spinal stenosis is the cause of your symptoms. And if you have 4 out of 5 of these, then there's a 76% chance that your symptoms are due to spinal stenosis. Pretty cool there. You can get pretty specific. So age greater than 48, leg pain greater than back pain. Leg pain, numbness, and tingling is often increased or worse with standing and walking. And this points to the possibility of something we call neurogenic claudication, basically a compression of the nerves in your spine when you stand upright. When you stand upright, you reduce the spaces where the nerves travel, and if you have stenosis or something like that, then they are further compromised. Now, real quick, before we just say, yep, that makes sense, that's me, well, let's prove it. I want you to prove something to me. I want you to prove that you actually do have symptoms that are worse when standing and walking. Is it possible that the way that you've been walking and standing is actually the reason you hurt? And it's not actually walking and standing that's the problem. Hang in there with me. I want you to do something called the up tall test. Right? And so many people who have spinal stenosis and or folks who get a little bit older, they tend to walk a bit pitch forward. And they say, ouch, my back really hurts. And guess what the surgeon says? The surgeon says, hey, do you have pain when you're walking and standing? You say, yep, but they don't take a moment to actually watch how you're walking and standing. And so in this position, they just assume, oh, well, the reason that you hurt when you're walking and standing is because you're pinching down on the spaces where the nerves travel. But most people walk a little bit bent forward as they get a bit older. And that would actually open the spaces in the spine. Well, what if we did something kind of funky here? It's well known that the further you bend your body forward from, say, a plumb line, an upright line here, the harder your back muscles have to work. And so if we stand you up tall, we should further compress the nerves in the spine and make you feel worse if you have lumbar spinal stenosis. But if, when you stand up tall, your symptoms actually feel better, then it tells us something different. It tells us that this whole time you've been led to believe that the reason that you hurt when you're walking or standing is because you have spinal stenosis, but it's really just because you're making your muscles work really hard. And the harder you make your muscles work, the more you contract them, the more you reduce blood supply and oxygen. You're constantly squeezing them. And when I give them some sweet relief by walking with my hips underneath of me, probably a habit that you're walking like this, maybe you don't even notice it, ask someone else, look in a mirror. It's possible that you're just reducing the amount of load through the spine, increasing the blood supply and oxygen to the muscles. It's just easier for your body to function like that. And so there's multiple outcomes from this. If you say, Charlie, that feels better. I consciously have made an effort to pull my hips underneath my shoulders and that feels much better. Well, then you do not have lumbar spinal stenosis because the more you stand upright, the more you should clamp down on those nerves. But in your case, if you're watching this and you feel better, the more you clamp down on the nerves, the better you feel. It's not a nerve clamping down problem. It's the fact that the more upright you are, the less your muscular system has to work. If you have no difference, the more upright you are, then you do not have lumbar spinal stenosis because this should make it worse. And if you say, ouch, Charlie, nope, that does make my leg pain, numbness, tingling worse, then you likely do have lumbar spinal stenosis, LSS, due to neurogenic claudication. All right, so final things. Relief with sitting, bending, walking bent forward, walking uphill, or leaning on a shopping cart. It's possible, as you just learned, leaning on a shopping cart may make you feel better, not because it's opening the spaces where the nerves travel, but because it's taking the strain off your lower back muscles. Try ditching the shopping cart and pulling your hips underneath, the up tall test. But again, if you have spinal stenosis, you should get relief with sitting, bending, walking forward. And it should make you worse to walk up tall. And the final sort of predictor, if you will, of spinal stenosis in this test cluster is symptoms in both legs. Oftentimes you'll see symptoms in both legs, but again, at this point in the flow chart, we're just talking about symptoms in one leg. So you've got it just in one leg, so what could be the cause? Well, if you have one-sided symptoms, then the most likely cause is what we call lateral recess or foraminal stenosis. Foramen, those are the holes where the nerves exit, like we talked about, so it's possible you have some arthritis taking up some of those spaces. And because it's a one-sided problem in the recess or the foramen, you'll have one-sided symptoms, just like the flowchart suggests. And ruling out symptoms in both legs, if you had all the other things that were present, 4 out of 5, then there's a 76% chance of spinal stenosis being the cause of your back, butt, leg pain, numbness, and tingling. So, Charlie, I did this test, a little tight, no problem, not sciatica. What else could be causing the problem? Well, it's possible that a disc could be causing the issue. Not very likely, because again, you got symptoms below the level of the knee into the foot. So we often don't see referred pain from discs and or from other structures go below the level of the knee, but it can happen. So is the disc causing the issue? Could be a smaller disc herniation. Could it be a disc extrusion? Could it be a sequestration? Well, it's possible. And again, these are the things which would increase the probability that disc is at play. So age less than 50 years old, central one-sided back pain, pain shifts, but again, we've got one-sided leg pain, numbness, and tingling. Trouble straightening or standing up, pain worse in the morning, pain worse sitting, driving, bending, lifting, twisting, coughing, sneezing. Pain better while walking, standing, or lying down. Roller coaster of back pain. And if you've got a right-sided disc protrusion, it's possible you got right-sided back, butt, leg, and even calf symptoms. And maybe you're shifted, left-sided symptoms. The difference here between referred pain and radicular nerve pain, and if you have a positive straight leg raise, then sciatica is very likely. If you have a negative straight leg raise, then no sciatica, all right? You do not have sciatica with a high probability. So the difference between nerve pain and referred pain is that nerve pain is very electric, burning, shooting, stabbing. People say sometimes electric, and it travels in a very narrow band, often below the level of the knee into the foot. Referred pain is often deep, achy, dull, kind of hard to pinpoint. It just hurts. In this case, maybe in your calf or something like that. So not very common, again, that things refer pain below the level of the knee into the foot, but it is possible. So facet joints can also do that, but again, not very common. So these are lower on the probability list. Do you have degenerative joint disease, arthritis, facet joint issue causing that referred pain? Again, maybe if you're a bit older. If we look at the research here, we see maybe you have symptoms all the way down the leg, into the calf, into the lower leg, but was the onset of your symptoms just off the one side of the spine? That may increase the probability you have a facet joint or arthritic problem. You have no pain when getting up from sitting, coughing, sneezing, or straining. You have pain that's better while walking or sitting. And again, rotation extension test. We did this earlier. If you haven't said yes to anything else and you're here, try standing. Twist to the painful side. Don't back bend yet. Then bend straight backwards after you've twisted. And if you're able and you can tolerate it, try working up to 10 reps. And you say, hey, Charlie, the more I do it, pain stays the same and or it gets worse. Okay, symptoms aren't really moving. There's no centralization occurring. Facet joint probability goes up. You say, ouch, that hurts, but actually that's weird. I had pain in my calf, but now it's just in the back of my thigh. The pain is moving closer to the midline. Or I had pain in my calf in the back of my thigh, now it's only in my butt. Or I had all those symptoms and now it just hurts in my back. Centralization doesn't occur with an arthritic joint. It could potentially occur with disc problems, only about 50% of the time, but still, this would increase the probability it's disc. And if that doesn't hurt, again, maybe a disc problem. Maybe it's a motion that you're going to have a preference for. All right, let's move on. Let's just say you do not have lower back pain, but you do have one-sided buttock, so no lower back pain, but you do have one-sided buttock and leg pain with or without numbness, tingling. It travels below the level of the knee into the calf, shin, or foot. Often described as sharp, shooting, electric, burning, cut my leg off type pain. So, we just went through this one up here. The only difference between the one we're going to talk about now and this one is that this has back pain. What if you don't have back pain? You just have pain in the butt going all the way down the leg into the foot or below the level of the knee. Very common. First question would be, does moving your back reproduce your buttock and or leg pain? Just because you don't feel pain in the back doesn't mean it's a back problem. It's actually very common, and the most likely cause of this is actually a back issue. You'll see that in a moment. Self-movement test, back bends. These are the 3 most common back motions that will reproduce pain in your butt and or down your leg, even if you have no back pain, which, as you'll see here in a moment, points to it being a back problem. So what I want you to do is I want you to stand on up and I want you to bend backwards just one time. Now understand that the value of any self-movement test in this flowchart is in direct proportion to your ability to tolerate it. If you can't tolerate it, it's not going to be helpful, okay? So if you're not able to do it, no big deal. But try just 1 rep for me. If you're okay with that, then you can move on. If just test number 1, bending your back straight back, shoots pain in your butt and down your leg, it's a back problem. We're going to talk about what that is. You flick the switch in your back. I don't feel pain in my back, but when I move my back, it hurts. It's a back problem. If that was okay, what I want you to do is do test number 2, rotation extension test to the left. So stand up, twist to the left fully, and then bend straight back. If that hurts, ouch, Charlie, it's a back problem. We'll talk about what that is. If that's okay, go ahead, twist your trunk to the right, and then bend straight back. Ouch, Charlie, that hurts. Back problem. We'll talk about what that is. But it's possible it doesn't hurt. So we got yes and no for you. If, by the way, this is the most likely scenario, if you said, yes, I don't have pain in my back, but I have pain or tingling going all the way down the leg into the foot, boom, bending my back hurts, back problem. Now what I want you to do is I want you to do a self-movement test, the seated straight leg raise test, and do this on the painful side. Go slowly. If you say, hey, Charlie, it's a little tight, but no major problem, it's possible that even though you don't have back pain, you have spinal stenosis. If this test is negative, this leg raise test, again, high certainty, 95% certain or more that you do not have sciatica. Is it spinal stenosis? Again, we go through this article, which suggests that there are a cluster of findings which can predict spinal stenosis with a high probability. So age greater than 48 years old. Is your leg pain greater than your back pain? Do you have leg pain, numbness, tingling to increase with standing and walking? Do you have relief of pain with sitting, bending, walking, bent forward, or leaning on a shopping cart? Does that make your leg pain, numbness, tingling get better? Do you have symptoms in both legs? Well, no, you don't have symptoms in both legs, and we'll talk about what that means in a second. Okay, so let's just say this real quick. You've got increased pain standing and walking. Is it possible you have neurogenic claudication? Let's follow this one out. Go ahead and prove it. What I want you to do is I want you to try going from a bent forward walking position, which most of you probably would be in, to really trying to be aware of pulling your hips underneath your shoulders. What this does is it should actually increase the pressure on the nerves. So if you have spinal stenosis, you should see it. This makes you worse. But it also reduces how hard the back muscles have to work. It often makes people feel better. So if you say, hey, that feels better, you do not have spinal stenosis, LSS, lumbar spinal stenosis. If there's no difference, again, you do not have spinal stenosis because it should make you worse. If you say, ouch, that definitely makes my leg pain, numbness, tingling worse, then you likely do have neurogenic claudication as a result of lumbar spinal stenosis. And symptoms in both legs? No. You have symptoms just in one leg, and chances are you have what we call foraminal or lateral recess spinal stenosis right in this area, and you will see that you have one-sided symptoms. It's a one-sided compression or problem, one-sided symptoms. Now, the more likely kind of path or flow for most people is that you're going to have pain moving your spine, and then you're going to do this leg raise test, and you're going to say, ouch, that hurts. Pretty much have sciatica, all right? The probability goes way up. And so what I want you to do now is I want you to do the straight leg raise test on the pain-free leg. And we call this a cross-straight leg raise test. And if you say, ouch, Charlie, that hurts and causes me to feel pain in my painful leg. So I do the leg raise on my bad leg and it hurts, but I do the leg raise on my good leg and it causes pain in my bad leg. We call this a positive cross-straight leg raise test. And again, this really shifts the probability to it being a disc problem. Very diagnostic of a disc issue. But let's just say, hey, I did it on my good leg, and raising my pain-free good leg is fine. Still, again, likely a disc problem. Now, you might say, well, what kind? And I see this very commonly. So there's certain types of disc problems that cause kind of what most people would consider to be a little bit of a different presentation that most people are used to. So number one, large disc herniation or protrusion, disc extrusion, very common, or disc sequestration can cause you to feel no back pain, or I had some back pain and my back pain went away, and then a couple weeks later, a couple days later, my leg is on fire. My leg is the problem, my back feels good. Very common with disc extrusions. And again, the presentation is different than that of a classic disc herniation. These are more common in people, again, who are less than 50 years old. And again, there's very little to no back pain in many cases. Or there was back pain, the back pain went away, but now you have raging leg pain. So primarily leg pain is the problem. Unloading feels best. Lying down or decompressing, these are people I work with who start by laying on their belly, when they're chatting with me. Disc extrusions, pain is often better while sitting or reclined. Unloading the spine. Giving space for that extrusion to breathe, giving space for the nerves in the spine to function. Pain is often worse while walking and standing, while loading the spine. As you'll see here in a bit, disc extrusions can actually cause stenosis. You can have spinal stenosis caused by a large disc extrusion, herniation, sequestration. Pain is often worse while standing and walking. A back bend is generally yucky, but forward bending is often something that feels good. And you can see here, a large disc protrusion, somebody bending backwards and somebody bending forwards. If the disc is intact, then you can see it when bending backwards. Oftentimes, you'll see that pain is increased. and the protrusion and or the pain that is felt because you're clamping down on the extruded part of the disc is worse. But when you bend forward, you might actually get some relief. It might feel better because you're not clamping down on that painful large disc issue. Again, bending backwards can reduce the space where the nerves have to function, reduce the size of the foramen. If you've got a large disc extrusion taking up room already, and then you bend backwards, you're going to take up even more room and it's going to hurt. If you bend forward, you might be able to leave some breathing room there. You might be shifted, you might not be shifted. So that's the most likely cause. If you've got no back pain, just one-sided, leg pain, numbness and tingling, pain in the butt, but I don't have any back pain, that's what we're talking about. Now, which nerve is affected? L5 nerve, roughly 50% of the time. This is where people experience symptoms. The back of the leg mostly, a little bit on the side of the leg. If you have symptoms all the way into the foot, you'll see comes across the shin into the big toe area. If you have a large enough disc issue that is compressing the nerve, you can see loss of function, specifically as it relates to the strength. So the way you test the L5 nerve is by walking on your heels. So go ahead and give it a try. Go heel walking. Try to walk on your heels. And oftentimes you'll see you won't be able to do it, or that you may struggle. On the one side, you might have foot drop and or the inability to lift the toes with as much strength as the other side. Most common nerve affected. The second most common nerve affected is going to be the S1 nerve. These two together account for 96% of probability there. All right, so S1 nerve, for sacral nerve, a branch of the sciatic nerve, symptoms almost exclusively in the back of the leg, does not wrap on the top of the foot, it is on the sole of the foot. If we look closer at the foot, we will see that the S1 nerve gives feeling to the heel, and you'll often see people have like plantar fascia type pain along with sciatica type stuff. It's not plantar fasciitis, it's the S1 nerve being irritated and causing symptoms in that area. You also see symptoms down to the pinky toe. If we look at strength, what we will see is that you might lose your inability to go up on your toes. So what I would recommend you do is try a bunch of calf raises. Go on your pain-free side and go ahead and do a bunch of calf raises. Count how many you can do, and then try going up on your toes on your bad side and see what happens. It should be very clear and obvious if you've lost function of this wire, of this nerve. L4 nerve, very common, 4%-ish of people. You can have sciatica pain or leg pain, I'm saying, in the front of your leg. And again, a branch of the sciatic nerve does go to the front of the leg, the L4 nerve. So this is where you may feel loss of feeling and or weird sensations, okay, funky feelings. Unlike the L5 nerve and the S1 nerve, L5 nerve, again, to the shin muscles, pulling your feet up. S1 to the calf. The L4 gives strength and function to the quadriceps. So what you would do is a single leg sit to stand. It's the best test that we would use, and a self-test that you can use at home to determine is there weakness in the L4 muscles of the leg. So go ahead and do pick the good leg first and do as many as you can safely on the good leg, and then try it on the bad leg and see if there's a clear difference side to side. A nice self-movement test for you there. Another self-movement test to further increase the probability that L4 nerve is the issue is a belly knee bend test. Go ahead, lay on your belly and try bending your knee as if you're trying to touch your butt, as if you're trying to touch your heel towards your butt. And here's a couple possibilities. So up to this point, we know you have a positive straight leg raise, because otherwise you wouldn't be at this portion in the flow chart. So the fact that you have a positive straight leg raise tells us there is sciatic nerve sensitivity. L4, L5, S1, S2, S3, these are the nerve roots which make up the sciatic nerve. And so if you have a positive straight leg raise test for pain and restriction of motion, and you have a positive belly knee bend test, meaning it was painful as well, and reproduce your pain, numbness, tingling, or your symptoms, this points to an L4 issue, because L4 is the shared nerve root between these two peripheral nerves, the sciatic nerve and the femoral nerve. Now let's just say the straight leg raise test was positive, but the belly knee bend test was negative. It was no problem. Well, then the L2, L3, L4 nerve roots are fine, and so that further increases the probability you have an L5, S1 issue within that sciatic nerve. All right, so there you have that. All right, so let's go back to the base here now. We went through the Charlie, yes, when I do back bends, it reproduces my problem, and I went through this test and so on and so forth. But let's just say you did these back bends and you were the exception. It did not bother you. You said, nope, no problem. I can bend my back, twist it right, twist left, all that stuff, no problem. I want you to still perform this straight leg raise test to kind of rule in or rule out sciatica. So let's go ahead and let's do that. Again, seated, heel on the ground, slowly raise it. It should be very clear if it's yucky or if it's painful. And if you say, hey, a little tight but no major problem, not sciatica, it's possible that you could have some referred pain from the piriformis, or you could have some type of like deep gluteal issue. Not very common. The more common flow or path would be, hey, Charlie, I do that. Bending my back doesn't cause the problem, but when I do my leg raise, ouch, that hurts, and it reproduces my leg pain. So it tells us you do have sciatica, but you can bend your back, and bending your back is fine. So it doesn't seem to be a back problem. It's got to be something below the level of the back. And what's possible? piriformis syndrome. Now, it's not very common. So just to give you an idea, like 0.3 to 6% of cases of back butt sciatic pain cases are due to piriformis syndrome. So pretty darn rare, but let's just say that's where you're at. Now we see some more details here to further increase the probability that piriformis syndrome is the cause of your symptoms. First things first, a little bit about the piriformis. Here it is in your butt cheek. So this is someone's butt cheek kind of opened up. This is the muscle, and this is the nerve. So everyone has a piriformis that is contacting their nerve, but most people don't have symptoms. So it's okay if your piriformis muscle is touching your nerve. It's compressing it in everyone. But there are different relationships of the piriformis muscle to the sciatic nerve. Most people have this type 1, if you will, piriformis sciatic nerve sort of, setup, 85%, whereby the sciatic nerve goes below the piriformis, beneath it. 15% of people have these other types of orientations with regards to the sciatic nerve and the piriformis. Let's look at those. Most common, 85%. But some people have a sciatic nerve that splits through the piriformis. Other people, part of it above, part of it below. All through, etc. Now, the reason I want to share this, because I can't tell you how many people say, well, Dr. Charlie, I have piriformis syndrome, and maybe it's not fixable because I'm one of those people who's an anomaly and has the nerve that goes through the piriformis, and you can't fix that. Well, newsflash, based off the latest research, we found no significant differences in the prevalence, meaning how common it was, of piriformis syndrome, buttock pain, or sciatica between people who had normal, the 85%, and variant, the other 15%, nerve anatomy. So you see this relationship between where the sciatic nerve is calls into the question of, does it even matter? Does it even matter where the sciatic nerve travels as it relates to your piriformis? The answer is not really. There are many people who have these things and they don't even know it and they don't hurt. So let's get into some self-movement tests though that are consistent with you having piriformis syndrome if they are painful or positive, we'll call it. So what I want you to do is I want you to go ahead and lay on your back, and I want you to get your leg in this position. We call it kind of like a figure 4 position. We're going to call it a figure 4 stretch test in lying down. And I want you to pull that leg up and pull that knee to the opposite shoulder as if you're trying to stretch your buttock. And if you have a piriformis problem, a muscle problem, you try to lengthen that muscle, which is aggravated, irritated, inflamed, whatever, it will hurt. It should hurt. This should be painful. If it's not, that would be weird. Now, also, if you have a muscle that hurts, that has been injured for whatever reason, and you squeeze it, you contract it, you try to use it, it should also hurt. So go ahead and do like a little clamshell, if you will. We're going to call this the piriformis contraction test on the painful side. And you should feel it in your buttock, and it should hurt. It should reproduce your symptoms. It may even reproduce the leg pain, numbness, tingling. People who have piriformis syndrome almost always have symptoms that are worse while sitting and driving due to compression. And they often have pain while walking, while climbing stairs, running, squatting, lunging, doing things like that. Not due to compression, because when you're walking, you're doing stairs, there's nobody putting pressure on your butt cheek, but due to contraction, due to the fact that you're working that muscle while you're doing those things. And oftentimes sitting on hard surfaces, believe it or not, is less painful than soft surfaces. Why? Research by McGill and some others basically compared the distribution of pressure when sitting on a soft surface like a ball compared to a hard surface. And what they found is that when you're sitting on a hard surface, almost all the pressure, the point contact pressure, is on your sits bone, your buttock bone, and the piriformis doesn't connect to the buttock bone. It's more in the soft tissue, and you can see when you sit on a softer surface, it distributes the pressure of sitting to other areas of the buttock, including the piriformis. So oftentimes you'll see it sitting on a soft surface makes people with piriformis syndrome worse. Sitting on a hard surface makes them better because they're offloading it, putting it just on their bones, not on the muscles of the buttock. Now, that's not always the case. You'll often hear, too, of people who have been diagnosed with piriformis syndrome, and they carry a cushion around with them because sitting on a soft surface is best. So then it calls into question, is it really piriformis syndrome or not? Some things to consider. So there you have it. We went through that entire flowchart. Let's move on. So now let's just say you have lower back pain with both sided symptoms, buttock and or leg pain with or without numbness or tingling. Let's go ahead and let's move your back to ensure that it is a back problem or to see if it's something else. So I'm going to ask you to be a little bit more thorough with this, and I'll explain why in a moment. It's important that we rule out the back because this is often caused by something else, something that is not mechanical within the spine. So go ahead, and what I want you to do is, let's just start with something simple. If you're sitting here right now watching this, again, you can go back and do this. I'm just going to kind of cruise through it. Start by moving the spine forward. And again, only do what you feel safe to do, only do what you feel you can tolerate. But go ahead and bend forward as if you're going to palm the floor. Go ahead then and bend, put your hands on your left knee and bend over top of your left knee and seated. Then put your hands on your right knee, bend over top of your right knee and seated. And again, this whole time you're asking yourself, does it hurt to move my back? Does that cause my symptoms in my back and both buttocks or legs? You're gonna go ahead and stand on up. You're gonna side bend to the right, side bend to the left. What does that do? If at any point any of these motions bothers you, you can stop. That answers our question. Now you're going to bend straight backwards. After doing that, you're going to twist to the right and bend straight backwards. After doing that, you're going to twist to the left and bend straight backwards. And this is sort of like a clock. Right? So you're going forward, you're going backwards, right, left, and you're going some in-betweens. You're really trying to move the spine in many different directions to make sure or verify that it is or is not part of the issue. And so most of you will say, yes, moving my back in one or more directions does reproduce my symptoms. And so what I want you to do is I want you to go ahead and I want you to do a self-movement test, which is the straight leg raise test, and I want you to do it on both sides. And you say, ouch, Charlie, that hurts, and at least one of those leg raises reproduces your pain, then chances are you have sciatica. And what could be causing both-sided buttock and or leg pain? Could be a disc problem. Now, it's not a smaller herniation or protrusion that's on one side. Why? Because you have both-sided symptoms, so we can rule that out. But it's possible it could be something we call a large, broad-based protrusion or herniation. So you can see here that this disc herniation takes up just like 25% of this kind of quadrant. But this extends and takes up more of the area. Kind of goes on both sides. It crosses this midline. So I alluded to this earlier, but you can actually see that disc problems, a large protrusion, can actually cause spinal stenosis of the central canal or other areas. So a large enough disc herniation can cause you to feel symptoms on both sides because it is narrowing the central canal. And oftentimes in these cases, you'll see again, folks are generally younger, less than 50. There will be little to no back pain, primarily the leg pain. Unloading often feels best. They just got to get off their feet. Maybe better while sitting or reclined to kind of create space where that large protrusion is, give it some room to breathe. Pain is often worse while walking or standing. A yucky back bend is almost always present. There's usually a yummy forward bend. Feels better, again, to create space back there. You can see here, extension can actually increase the protrusion. Bending forward can decrease it. And bending backwards can reduce the space where the nerves travel, and bending forward can increase the space where the nerves travel. And if you have something like this, which is this severe, both-sided symptoms, it's often a lifting, bending injury. Disc problem. Did that leg raise? Boom. Now let's just say it's a little tight, no major problem. So you move the back, did the leg raise, not a disc. Oh, straight leg raise is actually negative. Could it be spinal stenosis? We come back to this test item cluster. We say, if we got 4 or 5 of these ones right here on the screen, 1, 2, 3, 4, 5, there's a 76% chance that I have spinal stenosis causing my both-sided symptoms. So, are you greater than 48 years old? Do you have leg pain that is worse than back pain? Do you have leg pain, numbness, or tingling that is increased with standing and walking? Potentially causing, again, neurogenic claudication, compression of the nerves at the base of the spine. Again, you can prove it. How can you prove it? Force yourself to stand up even more tall, assuming it's tolerable, because you will often find that bending forward, even though you've been led to believe it should make you better, might actually be keeping you from getting better. Up tall test. Sink your hips underneath your shoulders. Make a conscious effort to stand up tall. And if that feels better, you do not have lumbar spinal stenosis. It should make you worse by causing further compression. If it makes you no worse, no better, no difference, you do not have lumbar spinal stenosis. If you say, ouch, that makes me way worse, then you likely do have it. Relief is often found by sitting, bending, walking bent forward, walking uphill or leaning on the shopping cart, but not always, as we just talked about. Symptoms in both legs. It's possible you can check this box off now because, well, if you're here in the flowchart, you do have symptoms in both legs. You can see here, the central canal, if you have some arthritis there, on some of the ligaments on the back of the spine, things like that, it can narrow the space for this central nervous system to function. And therefore, it kind of makes sense. You have a problem here, it causes symptoms down both legs. Or it's possible that you don't have central canal stenosis per se, but maybe you have foraminal stenosis or lateral recess stenosis on both sides. And even though it's not here at the center, it's on both sides, and so you're getting both-sided symptoms. And then often something to consider too is that if you're having symptoms on both legs and it's due to spinal stenosis, the onset is almost always gradual. Versus if you had a disc problem, it's almost always sudden, or there's some reason for it. There was some clear mechanism of injury, we call it. So, bending the back reproduces it. Leg raise, no big deal. Spinal stenosis, maybe, maybe not. It's possible. And I thought about whether or not I should share this, but it's possible that you could have something else. Very, very rare. But let's just say you have both-sided buttock pain without numbness and tingling. Maybe it just stops there at the buttock, but it's in both sides. It's possible. I've seen this several times. This is why I added it. You have something called ankylosing spondylitis. Again, not very common. 0.2 to 0.5% of folks. This is usually in folks who are younger, age less than 40 years old. It's twice as common in males as it is females. The buttock pain is alternating. It's here, and then it goes to one side, and it comes back, right? It kind of shifts around. There is stiffness, often just in general in the spine, loss of motion. Symptoms often ease with exercise and are worse with rest. Spinal stenosis is kind of the opposite. Disc problems are often the opposite. They get worse if they're that big, if the central canal is that narrowed by stenosis or by a disc problem. They often get worse by being upright and by exercising. In this case, symptoms are often eased with exercise and worse with rest and unloading. Genetic testing may, but not always, may reveal a positive HBLA27 genetic marker. And if progressed enough, X-ray will show a bamboo spine, kind of fusing of the spine, and this often affects the SI joints as well. So not very common, but I did want to throw that in there for you. We're back here. We've got both sided buttock and or leg stuff. You did the lower back exam. We went through the yes, but now we're like, no. What's going on now? Moving my back does not reproduce my symptoms. Probably not a back problem. Could it be a blood supply issue? We take some information, cluster of findings from this article right here. It's possible you could have something called peripheral arterial disease, a blood supply issue, and that's causing your leg symptoms. Some of the signs that would increase the probability you would have something like this would be buttock, thigh, and or lower leg pain, cramping or heaviness while walking that is consistent and consistently relieved with rest. Now that rest doesn't mean you have to sit down. You could just stand and take a rest. Talk about why in a moment. Generally occurs in folks who are older, age greater than 50. Maybe you have a history of smoking, high blood pressure, hypertension, diabetes, high cholesterol. All these things affect the cardiovascular system, the health of it. Now here's a really cool test that you can do to kind of tease this out and differentiate between maybe stenosis, spinal stenosis, a mechanical problem in the back, and or an arterial problem. Peripheral arterial disease, blood supply problems are exertional, not positional. Let me explain. Symptoms are related to how hard your heart works, not the position of your back. And that's how we can tease this out. Let's just say, for example, that you're walking and you're upright. And then I say, hey, stop, stay standing. You're still upright. The position of the spine does not change. But in this case, you're working. Your leg muscles are having to work. You're having to pump blood and oxygen to those muscles that are working. But then when you stop, those muscles don't really need to work much anymore. So the load on the heart goes down. If stopping to rest and standing reduces your symptoms, then it's possible and or more likely you have peripheral arterial disease, a blood supply problem causing your legs. If stopping to rest and standing does not reduce your symptoms, then it's possible you have lumbar spinal stenosis, and you may want to go check out that flowchart again. Now, another scenario, similar but a little bit different. So in this case, let's just say you're walking, blood is being pumped to the muscles, oxygen, nutrients, all that good stuff. And I say, okay, don't stop this time, no rest. Keep the load on your heart, keep your muscles working, but just change the position of your spine. Just bend forward a little bit. If you say, hey, bending forward does not reduce my symptoms, then this would increase the probability that peripheral arterial disease is the cause. If you do say, hey, bending forward reduces my symptoms, then it's more likely lumbar spinal stenosis is the cause. And again, neurogenic claudication could be occurring due to narrowing of the spaces where the nerves travel. There you have it. All right, now let's say you do not have lower back pain, but you do have one-sided buttock pain that may or may not extend into the leg with or without numbness or tingling. First thing we want to do is we want to determine, is your back or joints in or about the back part of the issue? So, does moving your back reproduce your pain? Let's go through the self-movement test, the back bends. If at any point doing any of these back bends reproduces the pain in your butt and or your leg, despite the fact that you don't have any back pain, then it appears to be a back or pelvic problem. And we'll talk about that. So stand up, bend straight back. If that's a problem, stop. Did they recreate your symptoms? If that wasn't an issue, go ahead, twist your trunk to the left and bend straight backwards. Is that an issue? Finally, go ahead, twist the right and bend straight backwards. Is that a problem? Does that reproduce your buttock and or leg stuff? If no, let's cover that real quick. If no, then what else could be causing your buttock pain? I want you to walk through the self-movement test. We're going to call it a figure 4 stretch test. We're going to do this in seated, and I want you to compare the painful side to the pain-free side. So maybe look in a mirror, have somebody watch you do this, or maybe just sit there and assess yourself. You can do that, but sometimes it's easier just to see yourself. Figure 4 stretch test. Compare the painful side to the pain-free side. You're going to have 2 potential outcomes. Let's cover this one first. Most common cause of, well, I don't have any back pain, but I have pain in my butt, is a stiff and painful hip. And so it's possible that when you go through the figure 4 stretch test, you notice that, let's just say for this case, you have pain in your right hip. Man, my painful side is tight. My knee sticks way up in the air with that figure 4 position and stiffer than the pain-free side. What could be the cause? Well, if you're greater than 50 years old, the most likely cause, no back pain, just buttock pain alone, would be hip arthritis, hip osteoarthritis. And each of these things I'm about to list off, for every check mark that you put next to these things I'm about to share, the probability goes up. So, female greater than male. Do you have trouble sleeping? Not always, but generally as things progress, sleeping becomes not as good. Do you have difficulty putting on socks, shoes, cutting toenails? Positive toenail test, we'll call it. And if you think about it, it kind of makes sense. That is the figure 4 stretch test in life. That's how it shows up in life. And as you can see here, we'll talk about this in a little bit, you can have buttock pain only that is caused by a joint problem, a hip joint problem. The most common location is the groin, but the second most common location is the buttock. And so here's kind of what that looks like. So you can see normal joint space here, black little gap there. And then you see narrowing of the joint space. And so this would be an example of arthritis on the one hip. Do you have pain with climbing stairs? Requires that you use the muscles around the hip. You load the hip, and it's often painful. Do you have stiffness in the morning? That improves a little bit with motion, but obviously if you walk too much or you move too much, as you'll see in a moment, it gets worse. So morning stiffness or stiffness after sitting for a while, that gets a little bit better with motion. Has there been a gradual onset? Arthritis generally doesn't occur overnight. So if you had a rapid onset of symptoms in your buttock, the chance that it's hip osteoarthritis is not high, because arthritis doesn't just show up in a split second. And generally, it gets worse over time. Not always, but worse over time. There's often pain and stiffness when getting up from a seated position or out of a car, because again, you kind of need to rotate your hip and your leg. And there's quite frequently a limp and pain in the buttock in this case with walking. The further you walk, the more you limp. Now, here's kind of a weird thing, and I just want to differentiate this for you. It's possible that when you went through the back motions, you went the wrong way. Because oftentimes people, when they do the back bend test, they will say, ouch, Charlie, it kind of hurts. But it might not hurt in their buttock, or it might hurt in their buttock, but they might also get a pulling or a pain. Now, I want to talk about this for a moment. So I have a picture of someone bending backwards and it causing pulling and pain in the front of the hip, but it may also have reproduced your back pain. So it's possible you went the wrong way. Maybe you haven't even reached this point in the video. If so, I'm sorry. But in some cases, if the hip joint is the problem, moving your back will cause you to feel pain in the butt. Not because it's a back issue, but because you can see here, the hip is extended. And so you're stressing out the hip. You're moving into a position which is not available to it. If you have a stiff and painful hip, when you bring it to the ends of its motion, it hurts. And so it's possible a back bend could be giving you a false positive, making you think it's a back problem because it's reproducing your symptoms, but it's really a hip joint problem. You've got to be savvy when you tease this out. So I wanted to put this here as a catch, as a safety. And oftentimes there's a wobbly walk. If you've ever been in the grocery store, you see people kind of going side to side, or their hips kind of shift side to side, or they tilt their body side to side. It's often due to a hip joint problem. Now, if you have a stiff and painful hip and you're less than 50 years old, maybe it's not osteoarthritis, it could be, but it may be a labral tear, an impingement of the hip. And oftentimes what will happen is you have a pinchy feeling in the groin, along with the buttock stuff. A painful motion is what we call fader motion, flexion, adduction, internal rotation. Basically, you're trying to twist your leg like a chicken bone the opposite way. And it's often painful, in the buttock in this case. And you can see here, there's different types of impingement. So this is like a normal hip, nice kind of shape to the femur and the ball there. You can see here, we call this cam impingement. So a cam lesion whereby the bone is kind of growing there. It's filling in this hollow. And you can imagine you try to move that up and it's going to pinch. You can see here, it's a little bit of a lip on the top of the socket. That's called a pincer deformity, morphology, whatever. Again, you try to move your hip up, you try to rotate your hip, try to pull your knee up to your chest, and you're going to say, ouch, that hurts. And you see here, there's almost like no socket. That's hip dysplasia. It does occur, but we won't talk too much about it. All right, now, let's go back to this test. Moving the back didn't hurt. I had to go through the figure 4 stretch test. So maybe when you do this test, instead of being stiff and painful, it's loose and painful. You may notice that your painful side is actually symmetrical in motion. The knee drops sort of equivalent one side to the other, symmetrical motion. Or you might notice that you actually have more flexibility on the painful side. What's going on there? Couple causes. Labral tear. I just said it could be stiff and painful. It could also be loose and or symmetrical in motion and painful if it's not too advanced. Pinchy feeling in the groin. Again, this motion of trying to rotate the leg out, spin the leg out, is painful. Often causes a pinch and pain in the buttock, groin, etc. And here are the different pictures. Cam, pincer, etc. Now, another potential cause could be something that impacts the sciatic nerve. So let's go ahead and let's do a straight leg raise test and see what happens on the painful side. Start with your heel on the ground, raise it on up. If you say, hey, Charlie, it's a little tight, but not too bad, and chances are you don't have sciatica. We know, for example, you have a negative straight leg raise that you can rule out sciatica with almost 95% certainty. So it's possible that you have something in the hip itself, and we just missed it. It's possible you have deep gluteal syndrome, piriformis syndrome, something like that. And for whatever reason, it's not aggravating your sciatic nerve. Not a high probability, but possible. Or more likely, you say, ouch, that hurts, and reproduces your buttock and or leg pain. In which case, again, sciatica is more likely. And could it be that piriformis syndrome is the cause? Moving your back didn't cause anything, so it's probably not a back problem. Your hip isn't tight, it's not a joint problem. Joint problems almost always cause restriction in motion in the hip joint itself. You actually have more motion, but moving your back doesn't cause it, but you still have pain in the butt. What's going on? Could you be one of the 0.3 to 6% of people who has piriformis syndrome? To review again briefly, piriformis muscle. Nerve goes right below it in about 85% of the cases. About 15% of people will have funky nerve to piriformis syndrome relationships. It pierces the muscle or does something wonky. Here's the cool thing. It doesn't mean you have to live in pain. Is it painful to be different? No. There are no significant differences in the prevalence or how common piriformis syndrome, buttock pain, sciatica pain is between people who have normal, hey, my nerve goes beneath my piriformis muscle, and people who have the piriformis, which is pierced by the sciatic nerve. A lot of people are going down the path of getting this thing released because it goes through the muscle. That's the problem. It's not the problem. Research does not support that. Some self-movement tests to further increase the likelihood of piriformis being the cause of your buttock pain. Lay on your back, do the figure 4 stretch test in lying. Pull it up, now stretch it. So when we just sat and we flopped it down, we didn't really stretch it that much. Now go ahead and pull on it as if you're stretching the piriformis muscle. Maybe this is an exercise you've been given because you told it's going to be helpful. Chances are it's just going to make you worse and it's going to reproduce your pain. It is a test that we use to reproduce pain, and you've been told to do it over and over again. Should be painful. Should be positive, we'll call that. If a muscle is the problem, piriformis is a muscle, stretching it should hurt, but also if it's injured, contracting it, trying to use it should hurt. And so go ahead and do this piriformis contraction test. Let's see what happens there. Little clamshell motion. Should be painful. Pain is often worse for people with piriformis syndrome while sitting or driving due to compression on that area of the soft tissue. Pain while walking with stairs running is often worse because you're requiring that you contract that muscle to get you up the stairs, to make you run faster, all those things. And believe it or not, sitting on hard surfaces is often, but not always, less painful than soft surfaces because of what the research shows. We see that people who sit on softer surfaces have greater pressure distribution to the soft tissue areas of their buttock. People who sit on hard surfaces, well, pretty much all of the pressure is right on the bone, the sits bone. And your piriformis is not a bone, it's a muscle. So this actually deloads. Hard surfaces may actually deload or remove the pressure from a painful piriformis. Something to consider. Okay? Now, there are people, again, who carry around cushions because they have piriformis syndrome, and that helps them too. So I'm not saying that all of these needs to be checked, but again, you're going for the most likely source of your symptoms based off of all these different findings. So we go back to the beginning. You did these back bends. We went through the whole no flowchart. Now let's just say, this is probably more common, that yes, that did, Charlie, reproduce the pain in my butt, maybe into my leg. What could be going on? 3 likely causes. A disc problem, as you've been backward, you're compressing a disc, which is causing you to feel pain in the butt. A facet joint problem, you're compressing a joint, which is causing you to feel referred pain in the butt. Or because the SI joint, the sacroiliac joint, is so close to the lower spine, a lot of times bending back will also cause pain with that. Nerve, very unlikely because, again, symptoms are not below the level of the knee into the foot. So here's what we need to do to tease these 3 out. I'm going to give you everything you need to know. We're going to use what we know about this phenomenon called centralization to help increase the probability of disc, facet, SI joint, or decrease the probability of these things. All right. So what is centralization? We touched on it a little bit earlier, but it's basically movement of symptoms from the periphery to the midline. So an example would be, hey, I have pain in my butt right now. And when I go do the movement exam, Charlie, that you're going to have me do here, the self-movement test, I don't have pain in my buttock anymore. It's there, but it's in my back. Or, I did a bunch of these things that you showed me, Charlie. I found a motion that now my pain is gone. That is centralization. You took a symptom that is somewhere in the periphery and moved it towards the midline or made it go away. You created a rapid change in your symptoms. Peripheralization is the opposite, moving symptoms more to the periphery, further away from the spine. Charlie, I got pain in my butt, a little bit in my thigh right now, and I did these motions and now it is in my calf or my foot. Neither centralization or peripheralization would be, hey, it didn't really move. So here's what I want you to do. Now again, I would stop this and I would go back to this. It's going to take a little bit of effort here, but this is the best way you can do it. You're going to go through each of these motions. First, you're just going to do 1 rep, and then we're going to go through 10 reps as tolerated. Again, the value of any of these self-movement tests is in direct proportion to your ability to tolerate it. So if you can't tolerate it, don't do it. Stop. Let's go through a repeated movement exam to see what happens to your symptoms. So the first motion, I want you to bend forward just 1 time if you can in standing. Again, if you can't tolerate, you can't tolerate, but see if you can do it. Take a baseline of your symptoms. Where do you feel symptoms? Where are they? Location-wise, how bad do they hurt? 0 to 100 or do 1 to 10. 0 is nothing, 100 is the worst. Pick a number. And where are they? Do 1 rep. Okay. Now go ahead and do 10 reps of a forward bend. And I want you to ask, what happens? At any point, does centralization occur? The more you do symptoms move, and do they move closer to the spine? Or does nothing happen? What happens? Standing forward bend. Now I want you to go opposite. So we went north, now we want to go south. Let's explore what happens as we move the spine. I want you to stand and I want you to do just 1 rep, see what happens. I know where my symptoms are, I know how bad they are, what happens with 1 rep. Now, if tolerated, go ahead and do 10 reps for me. Take note of what happens. Do symptoms move? Do they move further away? Do they move closer? Does nothing happen? Now, instead of doing things in weight bearing, let's do non-weight bearing. So now I want you to do just 1 rep of the kneaded chest. Make sure you're good there. And then if tolerated, do 10. And again, I want you to ask, what happens? Did symptoms move? Did they centralize? Did they not? Did nothing happen? Final motion. Lay on your belly. Push on up. 1 rep. Now do 10. Does centralization occur? That's what you're trying to assess for. Does a repeated movement exam move your symptoms closer towards your spine or eliminate them? And there's 2 possible outcomes that could come from this repeated movement exam. Either centralization did not occur or it did occur. We're going to walk through each of these. So let's just say you went through that, you say, Charlie, it doesn't matter how many reps I do, if I bend forward, if I bend backwards, if I'm lying down, if I'm standing, no centralization occurs. My symptoms don't move closer to the spine, and they definitely don't go away. Well, then I want you to go through some SI joint, SIJ, self-movement tests. Now, these are what we call pain provocation tests. They're essentially aimed to reproduce your symptoms. So just keep that in mind. And again, if things are super sensitive, maybe this is something that you want to hold off on and just continue to pick up some nuggets as we move forward in the flow chart. But either way, these are tests that you can do. So I want you to first perform the thigh thrust test. Take the painful leg, bring your knee up towards your chest, but not completely, so maybe just around 90 degrees or so. Take your hands and apply pressure downwards along the axis or line of the femur bone. So if this green arrow were to represent the femur, then go ahead and just push down in line with that femur. Give it some good pressure, and I want you to tell me, does it hurt or does it not hurt? And then I want you to go and I want you to perform the single leg bridge test. Now, typically, I would recommend that you put the painful leg down. So this shows you doing the thigh thrust test on the left and doing the single leg bridge test on the right, but try putting your painful leg down and lifting on up. And as you do that single leg bridge test, which is designed to kind of create some type of asymmetry in the pelvis, does that cause any issues, yes or no? And so are both of these SI joint pain provocation tests positive? Well, if they are, here's the cool thing. You can be roughly 70+% sure that SI joint is the cause of your pain. And so, how so? Well, we know that no centralization occurred, which essentially rules out the disc being the cause of the problem. There's, according to where you're at in the flow chart, no leg pain, numbness, tingling, weakness, or loss of feeling. So neurologically, everything appears to be intact, and the SI joint tests are positive. And you can see this drastically shifts the probability of it being an SI joint as the cause of your buttock pain compared to anything else. Now, there are some other things you're going to want to consider that would further increase the probability even beyond what you see here. So age greater than 50 years old. So just like facet joint problems, SI joint problems, arthritis in joints and issues in joints generally occur when people are a little bit older, so age greater than 50 years old. But you also see this here, pre/postpartum. Well, this generally occurs in females who are younger. So what are you talking about there, Charlie? Is it for older folks or younger folks? Well, generally older folks in the general population, but you will see a subset or a special population of women before and after pregnancy who get SI joint issues and or who are more prone to them. So before childbirth and after childbirth, there are hormones, relaxin, that is secreted to ease the pelvis for childbirth, so to make it easier to give birth, and this sort of loosens the ligaments and or makes that SI joint less stable. And the SI joint is a stress relieving joint. It has to accept loads from below and from above, and so it's really designed to be a stable joint. One-sided buttock pain. Now, obviously, if you're at this point in the flow chart, you have one-sided buttock pain, but I want to give you some more specific pictures and examples. So this is often where people will point. They'll point to this one part right at the dimple in the lower back on one side. They'll say, this is where I hurt. We call this a Fortin finger sign. So there's point tenderness to that area often. You can see this. Here I am working with somebody, Scott, who has SI joint pain. And where is he pointing? Right here at the dimple area. So a very common area for people to point to if there is an SI joint problem. Keep in mind that many things, though, can cause pain in that area. So disc problems can cause pain in the area, facet joint problems, SI joint problems themselves, obviously, as we're here. And so this is why we're working through this process. Now, location, again, just as important with other issues, it's important to help diagnose SI joint pain because location alone can help predict the most likely cause. Is it an SI joint problem or not? For example, You see here responders and non-responders. This is taken from a research article that studied the impact of SI joint injections on pain relief. And what we found is that when people drew out or mapped out where their pain was located, people who responded to SI joint injections, and SI joint injection being what most would consider to be the gold standard diagnostic sort of test, these people all had pain in the buttock, right at the dimple area and then in the center of the buttock. People who did not respond, meaning they did not have SI joint pain, predominantly had pain lower, so kind of at the crease of the buttock, almost like in the hamstring area, which we'll talk about here shortly. So it's kind of important that the symptoms that you feel, at least part of them, are predominantly in this area or the central buttock region. If they're lower down here, then this definitely reduces, again, location alone, reduces the probability of it being an SI joint issue. No pain above belt line. Not many people with SI joint pain feel pain above the level of the belt line. So you can see it's usually one-sided below. Facet joint as well as disc problems are generally above, but not always. Fall or accident is common, and or something that really caused like an asymmetrical torque, if you will, to the pelvis. So a fall or accident not required, but is often something that occurs in folks who have SI joint issues. Pain going from sit to stand, transitional pain. Disc problems can also cause this as well, but pain going from sit to stand is common. Pain rolling over in bed, again, or any asymmetrical movements, going upstairs sometimes even, stepping off a curb, lunging, stuff like that. And again, there's no numbness, no tingling because it's a joint. It is not a nerve. That's that. Now, you went through the SI joint test, and let's just say they were not positive. They didn't cause me problems. Well, again, what you can see is disc is still a possibility, but facet joint spikes and SI joint problems go way down, essentially 0% chance you have an SI joint issue, a nerve issue. Why? No centralization. Centralization is a phenomenon that is associated with disc problems. We're not going to, via repeated motions, be able to change the position of a joint at least all that easily, okay, without excessive force. So if you go through that repeated motion exam and you see that no centralization occurs, or it just gets worse the more you do it, but pain doesn't move and it definitely doesn't go away, then that increases the probability. Also, the presence of no major neurological issues, so no leg numbness, tingling, weakness, loss of feeling, anything funky there, points to it not being a nerve issue. And the fact the SI joint tests are negative increases facet joint as the most likely source. Again, we have things that can further increase the probability of it being a facet joint problem as we get a little bit older. Again, joint problems tend to occur, degenerative joint stuff, arthritis of the facet joints, all that stuff. So greater than 50. And if you have buttock pain, but the onset of symptoms when pain began started in the lower back and now it's here, then this increases the probability of being facet joint. Onset of pain is just one side, to the side of the spine, just off the midline. There is no pain when getting up from sitting. You see that in SI joint problems, there is pain often when getting up from sitting. In disc problems, there often is pain when transitioning, getting up from a seated position. Coughing, sneezing, straining, no problem, and pain is often better while walking or sitting. No centralization occurred. But what if it did? What if it did occur? Well, if it did occur, then this pretty much, without a doubt, points to disc being the issue. Again, as centralization is highly diagnostic of a disc problem, because we know, again, that an SI joint issue and a facet joint issue cannot centralize. We can't create rapid changes in bony structures like we can with soft tissue structures like a disc. So centralization, pain here. When I did repeated motions, regardless of the motion, by the way, sometimes it could be forward, it could be backwards, it could be while you're standing, it could be lying down, any of those motions, pain went to the back, it moved out of the buttock and went to the back, or it went away. And we say, well, what kind? Well, the fact that you don't have symptoms below the level of the knee into, the calf and or into the shin and or into the foot, but symptoms are just in the buttock and maybe a little bit in the back of the thigh maybe, points to it not being a large disc herniation, extrusion, or sequestration, as usually nerve problems are more common with those. So most likely a one-sided disc protrusion or herniation. Again, these are signs and symptoms that increase the probability that disc is the issue, on top of the probability that is increased already from the centralization that has occurred. So age less than 50, we see here again, younger folks, central one-sided back pain along the belt line may shift from side to side, or just one-sided buttock pain in this case. It's possible you did have back pain and then back pain went away and now you only have buttock pain. That's okay. An upstream problem, a disc problem, can cause you to feel pain in your buttock and sort of mimic or give you false positive SI joint tests when in reality it's really a disc problem, which is causing sensitivity of the SI joint region. All right, so disc problems, very common here. Trouble straightening or standing up after sitting. Again, you can kind of get that transitional stuff with SI joints, so not really sure that helps us. But pain worse in the morning, disc pressure is highest in the morning. Pain worse while sitting, driving, bending, lifting, twisting, coughing, and sneezing. Pain is often, but not always, better walking, standing, lying down. There's often this roller coaster of back pain. The back goes out, gets better, goes out again type thing. And if you have a right-sided disc protrusion back into the right, you will get right buttock symptoms, most cases. And you may or may not be shifted. If you have an SI joint problem, you're not going to be shifted to the one side. Facet joint problem won't be shifted. Left-sided, you'll see left-sided buttock pain. Maybe a right lateral shift, but maybe not. So let's just say now that you do not have lower back pain, but you've got more than buttock pain, right? You've got one-sided groin pain that may wrap around to the side and back of the hip towards the buttock. You have achiness and soreness occasionally and or potentially that may be felt in the knee, shin, or even the ankle area. So this is the location of symptoms we're talking about. And it's often felt in the distribution of what we call a C sign. We would call this a positive C sign. So people say, yeah, it hurts here on their hip, and they hold their hand like this, or when they show you where it hurts, they lift their hand up, and it's in the shape of a C. So groin stuff, it wraps the outside of the hip and then goes deep into the buttock. What could be going on? Well, I'll tell you right away, it's not piriformis syndrome. So many people come to me, they have this, say, I think I have piriformis syndrome. And it's not a piriformis problem. It ends up being something else. And why do I say that? Because the piriformis is located back here. The known referred pain patterns for piriformis are buttock pain, maybe some leg stuff, but buttock pain. Piriformis is not known to create outer hip pain and or groin pain. So the fact that you have groin pain and or even outer hip pain and pain in all these areas excludes the piriformis, because the piriformis will only cause pain in the buttock, the muscle itself. It may annoy the nerve, which could send some symptoms down the leg, but you will not get pain in the front of the leg. All right, so not piriformis. I just wanted to put that in there to be clear. So what I want you to do is I want you to go through a self-movement test to identify the most likely source of your symptoms. We're going to do the figure 4 stretch test. We've done this before. We're going to do it again. Compare the painful side to the pain-free side. Cross that leg up, let it flop, see what happens. Let it flop, see what happens. There's two possibilities. It's either stiff or it's not stiff. So let's just say your right side is painful and you notice, man, that leg, regardless of the side, I guess, is sticking up in the air. My painful side is tight. And when I do that figure 4, it hurts. And it's more restricted. What could be going on? Well, if you're greater than 50 years old, the most likely source of your pain is an osteoarthritic hip. And so here are some other symptoms and signs that would increase the probability of that being true. Female, more common than male. Trouble sleeping, usually the longer the problem is ongoing, the more trouble sleep becomes. But again, I put a question mark there because it's not a required factor, if you will. Difficulty putting on socks, shoes, cutting toenails almost always occurs. I call it a positive toenail test. Why? That is the figure 4. You trying to get your foot up there to put on a sock or a shoe is the yucky figure 4. So that's why you're having trouble with that in life. If you can fix that figure 4, you can cut your toenails again. Location, you can see that the groin is the most common reported location of symptoms for people with hip osteoarthritis or hip joint problems, but it can wrap around to the buttock. That's the second most common location. Now look at this. A large percentage of people report symptoms at the knee or below. So this is something to look out for. This is why I alluded to this earlier. Many times you'll go to see the hip doctor and you'll say, hey, my shin really hurts, my ankle hurts. And they'll say, oh, you got to go to the back doctor. So the hip doctor sends you to the back doctor, and the back doctor doesn't know what to do either. And it's because, for whatever reason, they're missing this referred pain pattern. And so it's very common that, in my experience at least, I used to work with hip and spine surgeons, that you will see people with osteoarthritic hips that will report knee pain, bad knee pain sometimes. Seems like there's something wrong with the knee, but it's actually the hip. Shin pain, ankle pain, you'll think it's due to sciatica or a back problem, and it ends up being a yucky hip. You can see here, normal hip joint space, little black area there, and then loss of joint space, osteoarthritic hip. Pain is often present while climbing stairs, requires you activate the muscles in the front of the hip, often causes compression of the joint, also requires that you work the muscles around the joint, which are often weak and or painful, and also requires that you load, kind of a single leg as you push up the joint itself. There's often morning stiffness that improves somewhat the more you move. It's often gradual onset of symptoms that gets worse generally over time. And well, if your symptoms came on suddenly, the chance you have an osteoarthritic hip is essentially zero, because arthritis does not come on suddenly. All right. Pain, stiffness getting up from a seated position or out of a car because you've got to move your hip in some yucky positions. And there's almost always a limp as things progress while walking. The further you walk, the more you limp, and or with increased activity. Occasionally what you'll see is you'll see back motions appear to cause the problem. You'll say, hey, when I bend my back backwards, for example, I get pain in my groin or even pain in my buttock. Just be careful here because this can be like a false positive. The back doctor may have you bend your spine in different directions. You'll say, ouch, that really hurts. And they'll say, yep, okay, it's a back problem. And the truth is that it's possible that when you're bending your back, well, you're also extending your hip. And we often see it, people with osteoarthritic hips have pain when extending their hips. And so it's possible that when you're moving your spine, you're just putting your hip in a yucky position, which is causing you pulling and or pain in those areas of the hip. It's stressing the hip joint. Okay, so false positive back motion. Not a back problem. It's possible that it's a hip problem still. And finally, we'll see a wobbly walk, Trendelenburg gait we call it. It's basically a fancy term for somebody who kind of like teeters back and forth as they're walking because they're trying to reduce the load on their painful hip. So now let's just say you do that stiff and painful. Maybe you're a little bit younger, less than 50, and or you don't fit those signs and symptoms. It's possible there's still a problem within the hip joint, and maybe it's impingement or a labral tear. Oftentimes you'll feel pinchiness in the groin, and you'll have a yucky motion. You will have a yucky motion, by the way. This fader motion will also be painful if you have hip osteoarthritis, but also with the labral issue where you try to pull it up kind of and twist it out. So you try to twist it out to the side. And again, you can see here the different types of hip impingement. So you have cam impingement, get a little bony overgrowth there, and you have pincer, top of the socket kind of starts to get an icicle on it, and you can see how that could, or imagine how that could restrict motion when you try to move the joint around. Now, let's just say that you do this figure 4 stretch test, and it's not stiff and painful. It is symmetrical. Right? These lines are either the same, so you've got equal flop towards the floor there with your hip motion, or actually it's pretty common that you'll see the painful side to be more flexible. What's going on there? Well, it could be labral tear. It's possible you just haven't seen the restricted motion yet, and so you will see, again, pinchy feeling in the groin, most common problem for an issue inside the hip joint. So a labral tear is a problem inside the hip joint, and again, this will be yucky. And here we go again, different types of hip impingement, if you will. Or it's possible that you have some type of bone stress injury, a bone stress reaction, or even a stress fracture. And so a couple things here. I would ask that you go through a self-movement test. Again, only do as tolerated, but a self-movement test. We're going to call this a single leg hop test. So go ahead and hop on one leg on the pain-free side, and then go hop on the painful side. And you will often feel a shot of pain in the groin or the pelvic region, maybe even the buttock. Every time you land, the impact will cause the pain. So if you have a bone stress reaction in the pelvis and or the hip itself, you'll see this hurts. Now, oftentimes you'll see people who get these bone stress injuries are athletes. So they're runners, putting on a lot of miles, or they're an athlete, just in general. And notice here, these things lump together. We call this the female athlete triad. Female. These things are more common in females, female athletes. And you'll see a cluster of things which increase the risk for bone stress, fractures, reactions, injuries. Irregular periods, missing periods, periods come and go sort of at more random times. Or maybe an eating disorder, or maybe the nutritional intake isn't what it should be. Which, these things together, hormonally and nutritionally, may cause low bone density, which would increase the risk of fracture. Right, so, somebody who's a little bit younger, somebody who's a female, somebody who's a runner, single leg hop, ouch, I still got motion in my hip, but I've got these other things, bone stress injury. Now, let's just say you're watching this, and you do not have lower back pain, but you do have one-sided pain on the outside of your hip, just isolated to the outside of your hip. I'm going to break it to you. You don't have piriformis syndrome. Yes, the piriformis attaches there, the tendon attaches there, but it's not a known referral site. Piriformis syndrome causes central buttock pain, not outer buttock pain in isolation. So what could be going on? Well, let's test out the hip joint. Is it a hip joint problem? Is it not? So let's see what motion you have. Go ahead, do the figure 4 stretch test on the painful side and on the pain-free side. And you're going to compare right to left to see, is it limited? Is it not? Now let's just say that it is limited. It's stiff and painful. It's tight. The painful side sticks up higher than the non-painful side. If you're greater than 50 years old, it's possible you have hip arthritis. Believe it or not, hip arthritis can cause isolated outer hip pain. Now you'll be told that you have hip bursitis, but if you have a stiff and painful hip, you probably have hip arthritis. That's how you start to differentiate. There's a loss of motion when you have hip joint problems, problems within the hip joint itself, what we call within articular joint problems. If you have an extra articular problem, extra meaning outside of the hip joint, bursa not inside the hip joint, it's outside the hip joint, then it will often not cause restriction of motion. We'll talk more about this. But hip arthritis, again, female, more common than male. Maybe you have trouble sleeping. The longer you've had pain, generally, the more the sleep declines. Difficulty putting on socks, shoes, cutting toenails, that positive toenail test, because that is a figure 4 functionally. Again, location-wise, yes, most common in the groin, buttock, and some other areas, but there are many cases of people who just have outer hip pain, so don't miss it. There is often pain while climbing stairs. There is often stiffness in the morning that gets better as you move about. It is usually a gradual onset of symptoms because arthritis occurs gradually over time, and therefore symptoms may get worse over time. There's often pain and stiffness when getting up from a seated position or out of a car, and there's often limping while walking. The more you walk, the more activity you do, the more you're loading the hip joint itself, the more you experience symptoms. And oftentimes there's this wobbly walk whereby people kind of teeter side to side as they're walking because it's painful and they're trying to compensate for weakness or issues on that side. So that's hip arthritis. Let's just say you're less than 50 years old, but you still got this stiff and painful hip. Oh, could be a labral tear. It's possible that not only do you have the outer hip pain, but you have some pinchiness in the groin. You probably would have discovered this already if you're watching this video, but this is probably an issue, and recreate your outer hip pain. A fader motion, flexion, adduction, interrotation, where you're trying to rotate that leg outwards, kick it out. And again, there's different types of impingement. You have pincer and you have cam. All right, so now let's say you have outer hip pain. It's not piriformis syndrome. You did the figure 4 stretch test. It is not stiff and painful. Your joint is not restricted in its ability to move. So therefore, it's not an in-the-joint problem. It's not hip arthritis. It's not a labral tear. Well, then what is it? Well, maybe when you do the figure 4 test, it's more flexible or it's symmetrical. It could be several things. The first thing that it could be is it could be something we call greater trochanteric pain syndrome. And we're going to lump hip bursitis and glute tendinopathy in this. So you have in the joint hip problems, which I alluded to, and then you have problems outside of the hip joint, in the muscles, in the bursa, in the tendons, things like that. Greater trochanteric pain syndrome. Look how close the bursa is to the muscle, the glute medius muscle, the glute muscles. They all attach on this bony point. If you take your finger and feel on the outside, or you'll be able to rub and feel a bony point on the outside. That's called the greater trochanter, and they attach there. And you can see it, the muscle ends in this tendon, which attaches right to this bone, such that when you contract this thing, it can move this bone. Greater trochanteric pain syndrome. Now, regardless of whether it's bursitis or a glute tendon problem, here are the symptoms that will be found. You'll have trouble sleeping on the painful side due to compression. You'll have pain going up the stairs, either due to compression or due to contraction of the painful muscle. You'll be tender to touch, and there'll be pain on the outside of the hip. And the glute tendon and the bursa do not refer elsewhere, so you'll feel pain locally in this area, just behind the point of that hip bone. You'll have what we call a positive jump sign. So what will happen is you'll go in to see a hip surgeon, they'll lay on your side, they'll push this area where I'm showing you, and you'll jump. You'll say, ow. That's what they call a positive jump sign. But it doesn't tell you if it's bursitis, and it doesn't tell you if it's a glute tendon problem, because both will be tender to that area. And yet what they will do is they will jump right to an injection. You have to be careful because injections can potentially weaken bone. And if it's a tendon problem and you want to be using that tendon for as long as you live so that you can walk and hike and bike and run and do all that stuff, then we know that generally when you put steroids around tendons, the outcomes are worse. You have to be very careful. Seems like a quick fix, but can make you worse long term. There's pain when standing on one leg. So oftentimes you'll see this position where when you stand on one leg, the pelvis wants to drop. These hip muscles on this side control the level of this pelvis. If you contract these hip muscles, let's just say on her right leg, then this left side of the pelvis would ratchet up. So if you stand just on one leg, stand on your good leg, and stand on your bad leg. You can make this into a test. How does it feel? Oftentimes it's painful in both cases, bursitis or glute tendinopathy or tendinitis. All right. Now, this is really the differentiator. And I'll show you some others here, but let's go through this test. All right. So you're going to probably have to pause this video or go back to it and try it on your own here, but come back to this. So this self-movement test is called the external derotation test. It's a really fancy way of saying you're going to put yourself into a rotated position. You're going to try to push out of it. That's it. So you can see here, if somebody was to do it to you, they'd rotate your hip into that figure 4 position, and then they'd say, push into me. Now, you wouldn't actually move them unless you're super strong, but you'd be trying to de-rotate it out of that position. Well, you could do this. Here's me. I'm just doing this up against like an ottoman or a chair. I get in this position, the other leg's straight, I get rotated, and I just try to contract into it. And the chair is heavy enough to where I'm not going to move the chair. All right? So this is what you can do. Now, there's 2 possible outcomes. You could say, ouch, that hurts, or it doesn't. All right, so let's just say, ouch, it does hurt. Then this points to being a glute tendon problem most likely. And the most likely tendon affected, just based off probability, would be the gluteus medius muscle tendon. And oftentimes we'll see this in 40 to 60-year-old females more than males, but 40 to 60-year-old folks who are generally more active. Now, the reason, real quick before I move forward, the reason that this test being painful increases the probability that it's a glute tendon problem causing your outer hip pain is because a bursa cannot contract. Bursa doesn't have the ability to contract. A muscle ends in a tendon, and when that muscle contracts, it generates force and translates force to a bone through the tendon to produce movement. And so here you are trying to produce movement, but there's resistance contracting the muscles, but not contracting the bursa because the bursa can't contract to begin with. It's not a muscle. And you get pain. This helps differentiate between, is it a contractile problem with the muscle itself, or a non-contractile problem, a bursa issue. So this is why you'll generally see it in people who are more active because they're working their glute tendons a lot. Another test you could do is you could do a side-lying leg raise. So go ahead and lay on your side, hand on your hip, try not to roll too far forward, too far back, just kind of stay square on your side, and go ahead and raise that leg up. And that should hurt because the glute tendon attaches from here to there, and when you contract it, when you squeeze it, it raises this leg up. And you should say, ouch, that hurts my hip if you have a glute tendon problem. If you don't, if that doesn't hurt, chances are you don't have a glute tendon problem. We'd have to look for something else. Now, the other possible outcomes, you say, hey, there's no pain or increase in my outer hip when I do this test. When I contract the muscles in my hip, which rotate and try to move my leg out to the side like that, I don't get any increase in pain in my outer hip. Hip bursitis, again, hip bursa is not going to be involved in that test or very minimally involved in that test because it cannot contract. So this increases the probability it's a bursa problem. So we typically see this in people who are ages 40 to 60 years old, very similar to the glute tendinopathies. They're not very helpful, but it's more common in folks who are sedentary. And if you think about it, it kind of makes sense. So if you come to me and you say, hey, Charlie, I have a glute tendinopathy, but I sit all day. I don't use my glute muscles all day. I don't stress out my tendons all day. I don't do things which produce a lot of force through my glute tendons, but I've been told I have glute tendinopathy. I'm going to say that's weird. But it's possible hip bursitis, if you're more sedentary, is the more likely cause. Now, I would still suggest you go through the same self-movement test. And this is more based off my experience. So go ahead, lay on the side, raise the affected leg up. Now, if you say, ouch, that hurts your outer hip, then again, probably more glute tendinopathy. But if you do this and you say, that doesn't increase my pain, remember the bursa can't contract, you could be causing some compression of the glute tendon over top of the bursa, but let's just say you're like, meh, doesn't really cause a problem. Or, even more clearly, let's just say you get relief of your symptoms on the outer side of your hip with contraction of the glutes, potentially via reducing pressure and compression on the bursa. Then this increases the probability a bunch that is hip bursitis. Why? Because it would be inconsistent to tell me that if you have a glute tendon problem, that contracting it and making it work harder makes it feel better. And so the fact that you can contract your hips via this side-lying leg raise and experience relief of symptoms in the moment tells me it's more likely a bursa problem, not a muscular problem. Hopefully that makes sense. Greater trochanteric pain syndrome, gluteal tendinopathy, hip bursitis, that's how you start to differentiate. Maybe though, that's not it. It's possible even if you have symmetrical motion and or more motion on that side. Again, maybe you have some pinchiness in the groin, but that's not the primary area. Maybe it's mostly on the outside of the hip. Still could be a problem in the hip joint. Could be a labral type issue. Call this FAI, femoral acetabular impingement, CAM, or pincer. Probably not likely, but possible. There you have it, outer hip pain. Last but not least, at least for the body stuff, let's say you're watching this and you do not have lower back pain or even central buttock pain. It's just one-sided near your butt bone without numbness or tingling. So, let's be clear. We'll call this spine pain here. Pain due to a disc problem, joint problem, issues in the back can cause problems there. SI joint is a little lower in that dimple area, central buttock problems. Sits bone pain. We're talking right down in this area, right where kind of the hamstring plucks onto the sits bone, your butt bone. First things first, we know that problems upstream in the back can cause you to feel pain here. Problems down here won't cause you to feel pain up here. Upstream problems can cause you to feel pain downstream, not the other way around. So we want to make sure it's not a back problem. So does moving your back reproduce your sits bone pain? So self-movement test, back bends. Let's go ahead and let's do them. If at any point, number 1, 2, or 3, throughout the testing, you notice that, wow, when I do that, it causes my sits bone pain, it's a back problem. Something in the back, and we can chat about that. But let's go ahead and let's do it. Stand on up, and I want you to bend backwards. Just 1 rep. If you need to do it 2 to test and see, that's okay, but just 1 rep is fine. Does that reproduce the pain in your buttock or the back of your thigh there? If yes, we'll go there in a moment. If no, we'll go there as well. If that's okay, go ahead and go to the next one. Rotate, stand up, twist your trunk to the left first, and then bend straight back. Rotation, extension, test to the left. What do we have there? If that's okay, go to 3. Twist your trunk to the right, bend straight backwards. What happens? There's 2 possible outcomes. No, moving my back does not reproduce my issue. Okay, let's go there. So now, if moving your back does not reproduce the pain in your sits bone, then it's possible you have a problem at the sits bone. Not a problem up here. That's why moving my back doesn't cause it. So it's maybe downstream. Could it be a high hamstring tendinopathy? This would be the most likely cause. Let's talk about it. What are some signs and symptoms that would increase the probability that your buttock sits bone pain is due to a high hamstring problem? Which, by the way, again, you have the muscle plucks onto the bone, and you have tendons, which over time can become unhealthy versus a healthy tendon, well-organized tissue. So generally we see this in folks who are younger, 20 to 45-year-old folks who are more active. Soccer players, it's very common in runners, things like that. There's no numbness and no tingling because it is not a nerve. We're talking about a muscle tendon unit. Sitting on a hard surface almost always makes it worse because, as we talked about a little bit earlier, sitting on a hard surface really increases the point contact pressure to your buttock bones, right where the hamstring attaches. It often hurts to walk upstairs or uphill, to walk or to run. Why? Because you are contracting it. You're requiring it to work, and you're putting force through that muscle, which ends in a tendon, which is dysfunctional. Or when you pull on that tendon, which is irritated, bending over, especially with the leg straight, you often get symptoms. So the onset of pain is often after a recent change, usually an increase in training volume or working out. So maybe running more miles, maybe you're training for something, maybe doing more squats, doing more deadlifts, maybe you started some HIIT class or program. Either way, this makes sense. Just going back to the hip bursitis, gluteal tendinopathy kind of differentiation. If you come to me and you say, hey, I'm 75 years old, I'm sedentary, I barely walk, I definitely don't run, I don't go to the gym, I don't train much, and I barely use my muscles, and somebody's telling you that you have a muscle tendon problem, then that doesn't really make sense. In order to get some high hamstring tendinopathy or tendon problem, you have to sufficiently load that thing to cause a problem. All right. So if you're sedentary, then the chance you have a high hamstring tendon issue, a loading problem of the muscular system, is not high. Instead, it goes to something more like an ischial bursitis, something that is not contractile. Maybe because you're sitting on your butt all day, you're putting a lot of pressure and therefore irritating the bursa on the sits bone. So the mechanism of injury, or how it starts, can make all the difference in the diagnosis here. Now what I want you to do is I want you to go through a couple self-movement tests, 2 specifically that will strain and or challenge the high hamstring tendon to do what it is meant to do. The first one is a diver test. Go ahead and do this on the painful side. It looks like a single leg deadlift. This places a lot of force through the high hamstring tendon, and if you say, ouch, that hurts my sit bone right there, Charlie, increases the probability it's a high hamstring tendon problem. If there's no pain or no problems, then could it be ischial bursitis? We'll talk about that briefly here in a second. Bursas don't contract. They're not contractile tissue. Therefore, if you're doing this, but you still have a pain in the butt, it's possible that that wouldn't be a problem. Now let's do another self-movement test, the heel dig test. Take the painful leg, bring it up to about 90 degrees, and dig the heel into a stationary surface, so a chair, edge of a couch, somebody's hand, it doesn't really matter. And what's really nice about this is, again, you're not moving. So you're not moving the bursa at all. You're just contracting that tendon. You're isolating for that. And if, when you dig the heel in and you contract that tendon, you say, ouch, that is my pain right here in my butt, then it increases the probability, along with everything else we've talked about, you have a high hamstring tendon problem. If that is negative, the chance you have a high hamstring tendon problem goes way down. It should hurt when you contract it. If there's no pain or problems, is it possible you have a bursa problem? Again, this wouldn't hurt a bursa because bursa doesn't contract. ischial bursitis. You can see the challenge here. Just like the trochanteric bursa, we were talking about greater trochanteric pain syndrome, was right near the glute medius tendons. Well, look what's right near the butt bone. You have the hamstring, which attaches right there in the butt bone, and then you have the bursa, which is like right there as well. And so the pain location is almost identical. Again, there's no numbness, no tingling, it's just a bursa. Sitting on a hard surface makes it worse, just like a high hamstring tendon problem. And the big differentiator would be no pain with the self-movement test. So you can contract the hamstring tendon. It doesn't cause the problem. The absence of pain with these contraction tests increases the probability it's a bursa issue. Hopefully that makes sense. Now again, you did the back bends, no. Went through high hamstring, no. Ischial bursitis, could it be something else? Let's make sure we don't miss it. So I want you to go through a straight leg raise test, but in a little bit of a different way. So on the painful side, to kind of tease out hamstring versus a nerve issue. So here's what I want you to do. A super savvy ninja test, all right? So step one, seated in a chair, hang your painful buttock off the seat. I know both my butt cheeks are on the chair in this picture, but go ahead and take your painful buttock and hang it off. Let's remove the element of compression from the equation. Then what I want you to do is I want you to slowly straighten your leg with your foot and toes relaxed, just like this, painful buttock hanging off. Then what I want you to do is I don't want you to move your leg. Keep it held there. Now I want you to just pull your toes slowly towards your nose. So we go from this, calf on slack, foot on slack, pulling your toes towards your nose. And you're going to notice one of two things happen. You're either going to notice that when you pull your toes up towards your nose, you feel some stretch, but it does not increase or reproduce your buttock pain, in which case this rules out a nerve problem, we'll talk about why in a moment, and increases the probability you have a high hamstring tendon issue. Now let's just say you do this, and you say, ouch, that's weird. When I move my foot, when I pull my toe up, my butt pain gets worse. What's going on? I'm confused. And then when I relax my toe, my buttock pain gets better. So when I point my toes, it gets better. When I pull it up, it gets worse. When I point my toe, it gets better. When I pull it up, it gets worse. What's going on there? Well, this points towards sciatic nerve sensitivity. Because if you think about it, here's what's happening. When you straighten your leg, your hamstring goes from here, your butt bone, to the back of your knee. Your hamstring is on tension. But there's one thing that goes from your back all the way down to the bottom of your foot, and it's your sciatic nerve. So what's happening when you pull your toes up without moving this area, so you're not changing this knee angle at all, so you're not lengthening your hamstring or shortening your hamstring or doing anything to your hamstring. All you're doing is moving your foot. And what's happening when you're moving your foot is you're pulling on your sciatic nerve. And so if when you move your foot, you feel pain up in your butt, it's not your hamstring, it's your sciatic nerve, the thing that connects everything, all right? By the way, quick tip, if you're doing hamstring stretches and you're putting a rope on the edge of your feet here, or you're doing a runner stretch and you're pulling on your toes and you're bending forward, are you stretching your hamstring or are you stretching your sciatic nerve? You're stretching your sciatic nerve. Be careful, okay? So, sciatic nerve sensitive, but due to what? What could be causing this? Something that is not very common, but I want you to be aware of, because I've seen it enough, and a lot of people miss this, is something I call an adherent nerve root, whereby the disc and or the tissue in the spine and the nerve, sciatic nerve, or a root of it, kind of adhere, sort of get glued together, for lack of better terms. Now the good thing is you can sort of unglue it and get moving, but the point is that it can happen. And so you'll generally see this in folks who are younger, folks less than 40 will say, and there's often a previous back injury, usually a previous disc injury. And here's how it will present. It'll present as major limitation in your ability to bend forward while standing. But while lying down, while seated, or even bending backwards and standing, you're fine. Okay, so here's what's happening if this is the case. You move your foot and you're like, wow, that causes my buttock pain. Now we're here. Could it be an adherent nerve root? Well, disc injury. Disc starts to heal. Sometimes you'll see this after spine surgery, by the way. We call this epidural scarring, about 6 to 8 weeks afterwards. And it's because you're not getting your nervous system moving enough. Or it could just happen, and that's okay. So let's just say right here, you have some tethering of the nerve, for lack of better terms, an adherent nerve root. So here's what's happening. So as you bend forward, your nervous system is all connected. So the top half of you wants to pull this way, the bottom half of you wants to pull this way, and if you're tethered in the middle, it can't do so. And so when the nervous system is on stretch, you will provoke your symptoms, and you won't be able to do this. You'll feel really restricted. It's almost like you just can't go. You'll feel a lot of tightness, maybe some pain, maybe even some numbness and tingling. Residual in the foot if you do this for too long. Your foot will fall asleep, for example. But then, when you put the nervous system on slack, in this case when I bend the knees, anytime I bend forward with the knees bent, I'm fine. Whether I'm seated, whether I'm lying, I'm perfectly fine. And when I bend backwards, I'm perfectly fine as well. There's no active disc problem or anything that I'm pinching on. It's simply a lengthening limitation, if you will, of the nervous system. Pretty neat. Not super common, but can happen. And can happen if bending backwards looks like it's not a back problem, but it could have been a back problem, and now it's sort of, you're left with this nervous system restriction. So bending backwards doesn't cause my symptoms. High hamstring tendon, bursitis, adherent nerve root, nerve sensitivity stuff. Okay, but let's just say it does. Just say bending backwards does recreate your symptoms. Well, the cool thing is we don't really need to worry about SI joint issues. You might say, well, why? Because again, studies clearly show that people who respond to the gold standard diagnostic test for SI joint issues, an SI joint injection, do not have pain at the sits bone location as the primary source of pain. They have pain higher up in the center of the buttock. And so the chance you have an SI joint problem is very, very low, even if bending backwards causes your symptoms, just based off the location. Now we can say, okay, is it a disc problem? Good question. Well, what kind? Well, again, because symptoms aren't below the level of the knee into the foot, and there doesn't appear to be nerve involvement based off the location of symptoms, probably rule out large disc herniation, protrusion, extrusion, sequestration, anything like that. And instead, it's probably a one-sided herniation, back to one side, whichever side you have buttock pain on. Again, symptoms of disc, signs of disc, generally younger, less than 50 years old. Central one-sided back pain along the belt line may shift from one side to the other. In this case, you may not have any back pain, and that's okay. Again, you don't have to have back pain to have a disc problem. Oftentimes, back problems can refer pain to the sits bone, and you think it's a sit bone problem, but it's actually a back problem until you move your back. There's trouble straightening or standing up after sitting. Maybe you predominantly have the buttock pain, but now that you think about it, it's like, I have had back problems in the past, and after I sit for a while, I do get some stiffness in my low back. Could that be the problem? Pain is often worse in the morning. Pain worse sitting, driving, bending, lifting, twisting, coughing, sneezing. Pain is often better while walking, standing, or lying. There's a roller coaster of back pain. Back goes out, gets better. There's a history of back problems. And again, if you have a right-sided disc protrusion herniation, you might have right buttock and or a little bit of upper thigh stuff. If you have left-sided, left stuff. Probably very unlikely to be shifted in this case with only buttock symptoms. So that's disc. Now, bending backwards hurts. It's probably a back problem, but it's not SI because of the location of symptoms. Maybe it's disc, maybe it's not. Could it be a facet joint problem? Could it be degenerative joint disease, arthritis, impacting the health of these joints? Possibly. Are you greater than 50 years old? If so, the probability goes up. Based off the research, you might have buttock pain now, but did your symptoms start here? And now they kind of faded and then they went to the buttock? If so, this increases the probability. Do you have pain when getting up from a seated position? Coughing, sneezing, straining? If so, probably not a facet joint problem, because there's generally no pain when you're doing these things with a facet joint problem. And pain better while walking or sitting. Not super helpful. But what you could do is you could do a rotation extension test. It's a self-movement test. So it appears as though bending backwards one way does bother you, but you could go further. You could do it repeatedly. So usually this is to the painful side. Rotate, extend, try it for up to 10 reps if tolerated, and see what happens to your sits bone pain. Ouch, that hurts. And you know what? It doesn't get better, or it gets worse. The symptoms haven't moved. There's no movement or rapid reduction in symptoms. There's no centralization that occurred. Facet joint problem would go up as far as the probability. You do this test, you say, ouch, that hurts, but actually it gets better. That's weird. I came in, I had pain here, I thought it was this problem, and now the more I bend my back backwards, it actually goes here. I didn't have this before though. Or it was kind of down on my thigh, and now it's all on my butt. That's weird. Bending my back not only can recreate my symptoms, but the more I do it, actually the better it gets. I can change the location of them, to change the intensity, or I can get them to go completely away. Disc problem, causing your hamstring problem. You've got to be sure throughout this entire process to rule out problems that are upstream first, because a disc problem can cause an SI joint pain, a piriformis pain, a high hamstring problem, plantar fasciitis problem, a calf problem, Achilles tendon problem. Upstream problems can cause downstream pains. Downstream problems do not cause upstream pains. Now, you've hung in there with me, and you're like, Charlie, I'm still confused. You're still confused about the cause of your pain. Nothing's adding up. Nothing's matching up, or it seems like many things could be wrong. I would be doing you a disservice if we did not discuss this, so I'm going to go on. Brain versus body. This is often the missing link for people who are lost and confused and feel like they have everything wrong with them or nothing wrong with them, and doctors can't figure it out. Up to this point in the conversation, we've discussed all of this stuff wrong with the body, whereby the pain that you're experiencing is due to a structural problem within the body, damage, if you will, to some joint or to some disc or to some tendon or something like that. Disc, facet, degenerative joint, all these different things. But is it possible that your brain is making a bit of a mistake? And did you know that it's possible the pain you're experiencing is due to danger, perceived danger by the nervous system? we call this central sensitization. You should know that your brain can cause real physical pain. Stuff is not made up and it's not in your head. If you feel it, it's real. It can cause very real physical pain, symptoms, sensations, funky stuff anywhere in the body to any extreme. It could be severe. And your brain can create real pain that mimics any of these issues within the body. So it could appear that you have sciatica because it travels below the level of the knee and the foot. You have a positive leg raise, and that's what you think. But then you're like, go through your flowchart, Charlie, and something's not adding up. Charlie, I just have pain on the right side of my buttock, and it hurts right here when I push on my buttock. It still might not be an SI joint problem, a piriformis problem. It is possible that your brain could be masquerading as or mimicking that issue, and everyone's missing it. So what do? We complete an evidence list. An evidence list is a tool, if you will, to help you look at the clues and be objective and help you figure out what really is the most likely source of my symptoms. I've gone through this very detailed diagnostic flowchart. I have gone through all of this stuff. And how is it possible that nothing's adding up? It's possible because you've skipped something. Maybe you need some more clarity, and if so, just let me know. Or it's possible that your symptoms don't add up for a reason. Maybe it's possible that nothing matches up with regards to the assessment that you've done because it's not a mechanical problem. And so I'm going to pull this up here in a second, and we're actually going to go through it together. Take notes. And if you answer yes to 7 or more of the 13 questions I'm about to show you, then the probability is such that your brain is most likely causing your symptoms. If you answer yes to 6 or less of these 13 questions, then it's possible that there is an issue with the body, but you just need further evaluation and testing. And I'm going to tell you in a minute here how, if you're interested in my help, you can do that. But first, let's open this up and let's go through the questions step by step so you can determine, are your symptoms of the body or are they of the brain? All right, so here we are, the evidence list. Let's go through this step by step. Humans are biologically wired to believe that all pain is physical. And you couple this belief with the overuse of x-rays, MRIs, and other diagnostic tests which pick up each and every possible wrinkle within the body, and people are convinced that they're broken. But is this really so? All pain is real, but that doesn't necessarily mean it's all physical. Pain can be caused by structural damage to the body, of which we went through in detail here today with this flowchart, but the brain is the real CEO. In other words, just because all pain feels physical or structural doesn't mean it is. It could be caused by your brain. Your brain might make a bit of a mistake. No matter how bad it hurts, where it hurts, what hurts, all that stuff, your brain can imitate any structurally caused pain. All right, so let's go through and answer these questions so that you can come to the best conclusion as to what's going on if you're still lost, confused, or you're just curious. All right, so we have 13 questions all here on the left side. I'm going to go through them and give you some context to answer them as accurately as possible. Question number 1. Are you unsure as to why your pain began? No clear injury or cause. So get that if you have an injury to the body and pain is actually due to damage of the body, you're going to know. Not many people say, hey, I injured myself, but I don't know how I injured myself, okay? I broke my bone in my leg, but I can't recall how I did that, okay? So structural problems have a clear reason as to why and when they begin. When you physically injure yourself, there's an immediate pain response. There's no question about what did it, okay? If there is no clear reason, no injury that you can recall. If you're thinking and feeling and, oh, I believe this is what caused it. Example, Justine believes that running caused her pain. Cindy thinks lifting weights caused her pain. Pete thinks years of bad posture caused his pain. No. If you're thinking, feeling, or believing or having to pull straws to come up with some reason as to why your pain began, then there is no clear reason, and you would have to answer yes. If there is a clear injury, you answer no. Is your pain chronic, lasting longer than 3 to 6 months? The body is designed to heal. You damage a bone, you break a bone. Better in 6 to 8 weeks, maybe 12 weeks max. Most disc problems reabsorbed within, say, 6 months. Sometimes maybe a bit longer. But either way, most things in the body are designed to heal within a 6-month time frame. And so if you're still in pain beyond 6 months, then you have to ask yourself, why is it that my body is not healing? Or is it possible your body is healing, but your brain has been trained to experience symptoms? Interesting. You can actually learn to experience pain. So, if your pain is chronic, longer than 6 months, we'll define that as. To be clear, we'll say yes. Did your pain begin during a time or around a time of fight or flight? Good or bad stress is what I'm talking about. So, having a baby, loss of a loved one, moving homes, locations, changing careers, career status, work environment, relationship changes, financial struggles, any of those things. Yes or no? Answer accordingly. Is your pain inconsistent, right? So if you break a bone It hurts every time you put weight on it. Some days it doesn't decide to not hurt, and other times it decides that it does want to hurt. If sometimes you can walk and you're okay, and other times you can't, well, your spinal stenosis isn't sometimes there and sometimes not. It's there in the morning, it's there in the night, it's there on Monday, it's there on Tuesday. So is your pain inconsistent? Is it the same and consistent day to day, or does it vary considerably? If it's inconsistent, say yes. Does stress trigger your pain? If pain comes or goes based off of stresses in life, work, family, life, financial, then this is a sign that symptoms are more of the mind than they are of the body. Anxiety, worry, stress, fear, frustration, they're all danger signals. And this can actually increase the pain that you experience. You'd have to answer yes. Do you experience relief of your pain with distractions? This is very common. Pain is a great preoccupier. If you are engaged in an activity that you enjoy, you go on vacation, and then miraculously your back pain goes away, or you're out eating with friends, or you're on a girls' night, or whatever, and you notice that you feel better. If you're at a rock concert, and you're like, hey, I was so focused on the music, like I didn't even know my back. Your disc doesn't know you're at the rock concert, or that you're with friends, or that you're in Bermuda on vacation. All right, so pain is a great preoccupier. Being engaged in an activity that you authentically enjoy can starve pain of attention and fear, which can make it go away because you're not focused on it. So you'd have to answer yes. Do you have pain, symptoms, or problems in other parts of your body? So it's common that people experience pain not only in the back of the butt, but also maybe in their neck or their shoulder, or they have knee pains, or they have foot pains, or they have other chronic things, by the way, not even necessarily related to the muscular system or the bones or anything like that. It could be, hey, I have belly pains, I have irritable bowel syndrome, GI problems, migraines, stuff like that. You'd have to answer yes. Does your pain shift, spread, move around for unknown reason? For example, did you have pain on the right side, and then all of a sudden it's like, well, that's weird, now it's on my left side. And then like, I had pelvic pain, and then when that went away, like then my back started hurting. And then when my back stopped hurting, then my shoulders started hurting, right? Symptoms that kind of move, spread, or shift around for unknown reason. Now, if there's a clear reason for it, okay. But for unknown reason, it's not consistent with a structural problem. If I have a right rotator cuff tear in my shoulder, I don't say, oh, it's in my right shoulder today, and then the next day I say, well, my right shoulder's fine, but now it's my left shoulder. It doesn't make sense. You'd have to answer yes. Do you experience delayed onset, question 9, of pain? You do something now but feel pain later. Very common. This isn't another clue or a piece of evidence, this is an evidence list, that you can use to increase the probability that symptoms are more centrally driven. So, do you feel okay while you're doing an activity? Walking, biking, hiking, going to the gym, whatever it may be, going to physical therapy. But then later on that day or the next day, symptoms are through the roof, you flare up. If I hit your finger with a hammer now, it hurts now. And it hurts later. Not many people hit their finger with a hammer and say, it was fine while I was hitting it with a hammer, but then the next day it hurt. That would be weird. That would be inconsistent with a structural problem. You would have to say, yes, I do experience delayed onset of pain, if that's true. Question number 10, have you been given many different diagnoses or no clear diagnosis? How is it possible you can be told you have everything wrong with you and still nobody can figure it out? Or how is it possible you've gotten all these scans and all these things and nobody can agree upon it? It's possible your symptoms are more centrally driven by the mind. There's a reason they can't agree upon it. So you would have to answer yes. Question number 11, do you identify yourself as a high-pressure, perfectionist, people-pleaser, type A, get-her-done, good student type personality? These types of sort of habits or personality traits, if you will, self-criticism, worry, high-pressure type stuff. If you are that person, it's okay, but you're more than likely stuck in a high-alert, more hyper-vigilant state than somebody who's not. Somebody who's more at ease. And if there is dis-ease psychologically within the system, there can be disease within the body. Okay, so just because you have these symptoms doesn't mean that this is the cause of your problems. Remember, we look at all these clues together. But again, it does put you more at risk for training those neural circuits to experience symptoms. Question number 12. Is it hard to identify yucky emotions that clearly and consistently reproduce your pain? Is there an unclear movement-pain relationship? Pain that is due to physical damage or injury to the body, to the tissues in the body, are clearly and consistently reproduced. If you take someone with sciatica who has an inflamed sciatic nerve, they're not going to sometimes be able to do a leg raise and other times not. It is going to hurt and be consistent from moment to moment, morning to night, day to day, until the inflammation or the irritation or whatever is causing it resolves. If you're somebody, this happens often, that has gone through the flowchart, and you're like, hey, it's tough because I don't have a clear and consistent movement-pain relationship. Essentially what you'd be saying is, sometimes things hurt and sometimes things don't, and I'm confused. Or, you know what, Charlie? I can go through your different movements and it doesn't really hurt. I just have a pain in my butt. What's going on? So you have yummy motions. You don't have any yucky motions. That's even possible. And what does it tell you? Your symptoms are not related to the movement system, at least not clearly related. And so it's possible your symptoms are driven more centrally by the mind. So you would have to say yes. And finally, has there been a lack of response to physical treatment? Have you tried many different treatments, but nothing's helped long term? Most treatments are aimed at fixing the physical body and only the physical body. What are the chances that you work with a specialist, many different specialists, and they all claim to know what the problem is and know how to solve it, and nothing works? Or it works temporarily, but the problem keeps coming back. What does that tell you? It tells you you're not really solving the problem. So if you're targeting the body and nothing's working, it's possible you're not getting the relief that you're looking for because it's not a body problem. It's not a mechanical problem. You need to focus on treating centrally the brain. So the good news is that regardless of the cause of your pain, brain or body, we work with people like you all around the world who want to learn how to heal themselves naturally. Chances are you've gone through this flowchart and you've identified the most likely source of your symptoms, but now how do you fix it? And so if you're interested in potentially working together and want me to review your case personally to see if I can help, go ahead, click the apply link below somewhere in the comments or the description. Thanks so much for watching and be sure to subscribe.